morning, and I would like to welcome everyone who is present in the chamber and those who are listening online to this morning's meeting of the Health Scrutiny Committee for Lincolnshire. I would also like to add, for those of us in the council chamber, there is no fire drill planned this morning. In the event of the fire alarm sounding, we need to leave the council chamber through the rear doors, through reception, and assemble in the car park at the front of the building and await further instructions. I would like to ask for all mobile phones to either be switched off or placed on silent, please. And I would also like to welcome Councillor Colin Matthews, who is attending online, I believe, as Executive Support Councillor for NHS Liaison, Community Engagement, Registration and Coroner Services. Other participants will be introduced when we reach their item. And please feel free to remove blazers if you're too warm. It's certainly a warm one again. We'll now move into agenda item 1. Apologies for absence and replacement members, please. Trina.
Thank you, Chairman. We've received apologies for absence from Councillor Smith, and we have Councillor Skinner as his replacement member, and we've also had an apology from Glynis Scalesi.
Thank you. In which case, I'll move on to agenda item 2, declarations of members' interest. Are there any declarations, please? No? Okay, thank you. In which case, we'll move on to agenda item 3, the minutes from the 15th of June. You'll find these on pages 3 to 15 of the agenda pack, and as the committee have had the opportunity to read these in advance of the meeting, I plan on taking these on block. Is there a proposer for those, please? Councillor Underwood. Thank you. Do I have a seconder, please? Thank you, Councillor Allen. All those in favour, please show. Thank you. Those against? And finally, abstentions. Thank you. I've got 3. Have you got those abstentions? Yeah, Councillor Skinner, Whittington and Dr Thompson. Thank you. In which case, we'll now move on to agenda item 4, the Chairman's announcements. My announcements have been circulated with the agenda on pages 17 to 22, and there are no supplementary announcements at this time. Are there any questions on the announcements? Councillor Wotton.
Yes, thank you, Chairman. Could you please tell me, have you given further information regarding the increasing COVID that's going on across the country now? Because I did read that they were thinking about bringing back free testing. And is there any information that's coming our way? Thank you.
I haven't heard any further additional information, but I will ask Simon the question and see if he's heard of anything. But yeah, the rates are certainly rising, and like I think we said a few months ago, I wouldn't be surprised if we see some form of restrictions coming forward again. Simon.
Thank you, Chairman. I'll put a call into public health colleagues and see if we can send something out in the next couple of days just to update if there's anything on this. There have been, obviously, in the national media, reports of quite significant increases, but I will get something hopefully a bit more localised. Thank you, Chairman.
Okay, Councillor Skinner.
Thank you. It's fluoridation. Presently, all the areas that don't have it, all down the East Coast, are the areas where we have quite a lot of rural deprivation, and the areas actually coincide. I just thought the committee would like to note that. Thank you.
Yes, thank you, Councillor Skinner. I think we're all very aware, and we'd all like to see the fluoridation, you know, being rolled out throughout. And so I think it's something that's going to, is it Children's Committee anyway? So they will be looking at that, and I'm sure they'll be more than happy to share what comes out from that meeting. Councillor Thompson.
Thank you, Chairman. Just a point on that, I think it's particularly worrying that those areas that are currently fluoridated are going to be scheduled for possible removal, and I think that that is a very, very backward step. Thank you.
Thank you. In which case, if there's no further questions, Councillor Cleaver.
Thank you. I'm pleased to hear that the integrated care systems are being set up as of the 1st of July, so we're a few days into them now. Are we constitutionally required to comment on the arrangements for integrated care on the ground? And is that going to happen if constitutionally we are? Because my reading of the legislation implies to me that we are.
Not as far as I'm aware, but I will pass it over to Simon because he's got more in-depth knowledge of the legislation as it stands.
I don't believe the role of the health scrutiny. I will check this, but I must say I'm a little bit surprised by the councillor's comment, but that doesn't mean to say that there might not be something in it. So I will check on this. I don't believe there is a role for the committee in advising on the constitutions of integrated care boards. The integrated care boards, their constitutions by and large are following a national template which has come from NHS England, but I will check this. Thank you, Chairman.
Sorry, I was referring more to the boards and the partnerships plans for how it's going to get rolled out on the ground, because that clearly hasn't yet been decided, and I hope that this committee will have a role and be consulted on how that should happen, particularly given things that I've heard so far as possible ways that might happen. That's all. Thank you.
And you'll certainly look into it. I know that Health and Wellbeing Board is sort of more heavily involved with it, and of course we take the sort of more active part of the scrutiny over all of NHS services, but it's something we'll certainly look into and come back on. So anything further? No, in which case do I have a proposal we note my announcements, please? Thank you, Councillor Wootton. Seconded, Councillor Skinner. All those in favour, please show. Thank you, that's supported unanimously. In which case, before we move into the substantive part of the meeting, I would like to ask that you keep your questions and contributions succinct and concise, and ideally no more than 2 questions per person per item. I'd also like to stress the importance of treating all of our contributors today with respect and to bear in mind our role as constructive scrutineers. We'll now move into agenda item 5, the Cancer and Living with Cancer programmes. This item was circulated as part of the agenda pack on pages 23 to 43. This includes a PowerPoint presentation in the pack and a short video of 2 minutes and 30 seconds. I'd like to welcome our presenters, Claire Raybould, Director for System Delivery of the Lincolnshire ICB, Sarah Jane Gray, Deputy Cancer Programme Manager for the Lincolnshire ICB, Kathy Macmillan, Living with Cancer Programme Manager. What we'll do is we'll hand over to you for the presentation and take questions at the end, if that's okay. Thank you.
Thanks. Morning, everybody. I'll just start. Thank you for the introduction. Just to apologise to the committee that Colin Farquharson, who is the Senior Responsible Officer for the Cancer work across Lincolnshire, isn't with us today, unfortunately, due to illness. But hopefully we'll be able to cover everything for you today. I think it's just important to set the context, and you'll hear this through the presentation, that all providers that we commission care from Lincolnshire for our patients, and right across the country, in fact, are working extremely hard at the moment to improve cancer services. You will have seen that in the media too. Clearly, pre the pandemic, we were in a difficult place with some cancer services, and also the COVID pandemic itself has had a huge impact, as you'll hear. We are currently in recovery from that, but again, as Councillor Wootton mentioned earlier, we are in a further wave of COVID infections at the moment that isn't currently impacting, but could potentially do that in the days and weeks coming forward. So just important for members to understand the context in which we're working with at the moment. So my team that are with me today, so I'll pass to Sarah Jane Gray. So she's going to talk to you about the cancer programme for Lincolnshire, and this is for the Lincolnshire population, so it's not specific to a provider, whilst Colin is the Senior Responsible Officer and the ULHT Medical Director. He oversees the totality of the programme for Lincolnshire patients. And then Kathy is later going to talk to you about the Living with Cancer programme, again, a really important programme. And there's some great work that you'll hear about hopefully during the presentation. So thank you for listening. I'll pass you over to Sarah Jane.
Thank you, Claire. As previously said, I'm Sarah Jane Gray. I'm the Deputy Cancer Programme Manager for Lincolnshire ICB, as it is now, as of the 1st of July. Previous to that, I've worked at ULHT that's United Lincolnshire Hospital Trust, in clinical and managerial capacity. On this slide, you'll see the agenda for this morning's presentation, which doesn't really require any further introduction. Very briefly, I'd like to highlight the key priorities for us this year as agreed with our colleagues at NHS England. As a system, we've set out our planning for 22-23, and our main priorities are to reduce the 62-day backlog, that's patients waiting over 62 days for treatment. Apologies, my slides are on the move by themselves. So that's reducing the number of patients waiting over 62 days for either diagnosis or treatment, and focusing on what is known as the 28-day faster diagnosis standard, which we'll go into a little further in a bit. This slide here that you're looking at highlights our 62-day performance, which, as you'll see, is below the national standard. Prior to going into COVID, our cancer teams were struggling with cancer. It's, you know, there's no hiding that. But when we went into the pandemic, we were really hit quite hard here in Lincolnshire. But across England, since I think it's January 2014, the 62-day cancer standard has not been met as a country as a whole. So I think that shows how difficult it is to provide cancer services at the moment. United Lincolnshire Hospital Trust is our biggest provider and does make up the majority of this performance, and they, as well as the other trusts that we cover, North West Anglia Foundation Trust and North Lincolnshire and Goole, have also struggled with similar tumour sites. The majority of the backlog actually sits in the colorectal tumour site. This was hit significantly by COVID. During COVID, we had to close down endoscopy due to it being an aerosol generating procedure. That created huge backlogs in itself. And we then had to look for alternative options. So we moved to virtual colonoscopy. But the majority of the capacity for the virtual colonoscopy was on the west of the county in Grantham, which understandably does not meet everybody's requirements. Other trusts, regionally and nationally, were already using virtual colonoscopy. It was something they'd opted to change their pathways to do. So they weren't hit in the same way that we were. Once endoscopy came back online, we only had 50% capacity due to infection prevention and control. So it just exacerbated the problem. Also, United Lincolnshire Hospital Trust brought in more patients to intensive care in HDU than any other trust regionally, which meant that we couldn't undertake some of the larger colorectal surgery. So I don't like to use the words, but it became a bit of a perfect storm. We had social distancing measures and already ageing buildings, which made it very difficult to provide the same levels of capacity we had. It all just resulted in large backlogs, and as you'll be aware, the pressure in the health system is huge at the moment, and not just in cancer, although the trusts have done their best to prioritise cancer. We're continually working with colleagues to try and find ways to improve cancer services, but it's not easy. I was on a national call with Professor Sir Mike Richards a few days ago, and the suggestions they were making are already things that we are doing here in Lincolnshire. So it is positive, but there is no real answers at the moment as to how we fix the problem. So we're working very hard and tirelessly to try and reduce the 62-day backlog. And until we do fix that 62-day backlog, the performance that you see here will not get any better, because what happens is when a patient is treated over 62 days, that works against this. And what the priority is at the moment is to treat patients in clinical priority, and also those that have been waiting the longest. While we're reducing the backlog, you won't see an improvement in this performance. I'm now going to go on to the 28-day faster diagnosis standard, and this will be, for those of you that are familiar with cancer performance, this will be a new standard that was brought in April 2022. It's intended to replace the 2-week wait performance. So what it means is that patients will hopefully be diagnosed quicker and have cancer ruled out within 28 days of their GP urgently referring them for suspected cancer. For those who do not have cancer, it puts their minds at rest more quickly. To support this approach, the 28-day faster diagnosis, we've implemented what's known as the best practice time pathways, and these are nationally approved pathways for each tumour site. So the intention is that we will implement them across all tumour sites before the end of this financial year. As you can see, we are below the national average for performance in the 28-day faster diagnosis standard, and that again is impacted by the backlog that we currently have. But we intend to meet the 75% performance by the end of March 2023. The slide in front of you demonstrates the 62-day and what we call the 104-day backlog of patients waiting across the 3 trusts. This performance dates back to May, as we work a month behind when it comes to validated cancer performance, but I can assure you that these figures have actually improved since May. And to be fair and to give every trust a level playing field, we're demonstrating what the figures were back in May, but they are getting better, and we are in we're acknowledged and to be in the 4th wave of COVID, and so far we haven't seen a significant impact on cancer yet, and which I think is testament to the hard work of those on the ground. As you can see here, if I just scroll over here, Lincolnshire, if you look at benchmarking, we are 7th from the bottom across England. As I've explained the reasons for that, that's because of the backlog that we do have. Once we begin to work through that backlog, we are confident that we will improve. There's some really great work has gone on during COVID, and some of the tumour sites that weren't actually performing pre-COVID have made some real significant changes. And some of the positives that have come out of COVID, virtual clinics, etc., have really had an impact, and there is some real determination to drive for change at the moment. Here you can see the geography of what we have our cancer alliances. Lincolnshire's a bit it's a bit difficult when it comes to cancer alliances because the 3 cancer alliances cover the Lincolnshire patients. In 2015, NHS England published a national cancer strategy that recommended the creation of cancer alliances. Now, they bring together expert clinical advisory groups to develop change and drive forward transformations. They are very positive. But the difficulties we have here in Lincolnshire, as you'll see in the yellow, that's the East Midlands Cancer Alliance. So that's that covers the majority of Lincolnshire. It's where the funding streams come from nationally down to the ground here in Lincolnshire. But you'll see in the red the East of England Cancer Alliance, which is what covers NWAFT, and in the north you'll see the grey, which is Humber and North Yorkshire Cancer Alliance, which covers NLAG. So what that means is the finance that comes into the system, the Lincolnshire ICB, is only to cover improvements at ULHT, not NLAG or NWAF. They have different funding streams. So it does make it very difficult, and the cancer alliances often have different directions in terms of what improvements they want to make. So it's, from our point of view as an improvement team, it can sometimes be very difficult to drive improvement because they want to make it slightly different across the patches. But we do our best to keep communication open between all trusts, and we invite them along to our cancer board, which we have monthly, which is either chaired by Claire, who was just presented before me, or our SRO, Colin Farquharson, who unfortunately can't be here today. So this is the governance structure. As you can see, I've just mentioned, we have the oversight through the cancer board. We have at least monthly meetings with North Lincolnshire and Goole, and we have fortnightly meetings with NWAFT. There's lots of other, we attend their cancer boards. There's also outpatient boards, etc., that we have a strong input into. And during COVID, those relationships with those trusts have actually gone from strength to strength, which has been really positive to see. But when it comes to, we have the oversight of those trusts, but as I've said, when it comes to implementing improvement work, we're very much directly linked with United Lincolnshire Hospital Trust, and we're more involved with the improvement that goes on there due to the way in which the funding streams work. I just want to go into the challenges and opportunities that we have at the moment. It'll be no surprise to you that urgent and emergency care pressures are huge at the moment. Demand is far outstripping capacity. We've also got reduced staffing, which does not help when demand is so high. This is due to COVID and the need to isolate. We often see staff needing to be redeployed for safety reasons to help out in urgent emergency care. Cancer, what I must admit we've been very lucky, has very much been ring-fenced most of the time, but there does come times when, for the safety of the patients coming through the front door, that you have to put them first. We're now starting to see intensive care becoming incredibly busy as well, which is likely to have an impact on the surgery for cancer patients that do need high dependency unit or intensive care input post-surgery. COVID, as I said previously, we're in the 4th wave. We're starting to see hospital admissions rise, and it is a real challenge for people on the ground to juggle the needs of those patients, because a cancer patient, while they're incredibly important, they're not extremely ill and in front of you at that moment in time, and sometimes we have to prioritise those that are coming through the front door. Workforce challenges are huge. It's not just a local problem, it's a national issue. We have shortages in many specialities. I could name a number of them to you, of which specialities we have issues in nationally. So to then recruit those people locally is difficult. They often want to go to larger cities. They want to go to bigger teaching hospitals where there's more opportunities. So we're trying to do our best to encourage people to come to Lincolnshire, and we do quite well with international recruitment. However, what we do see is people internationally will often come to us for a year or so and get their visa and then move on, which is not great for continuity of care. So it's a really difficult space, and it is acknowledged nationally that we do have an issue here in Lincolnshire and down in the north and the south. So all of our patients in Lincolnshire are affected by the workforce challenges that we see. And since the beginning of COVID, since post-COVID, we have seen a huge demand on for cancer. We have certainly seen more, if we were to even out our average, the referrals across the last few years, we've certainly seen a significant increase despite the drop that we saw during the first and second waves of COVID. Just as an example, last week we were at 114% against baseline, and that was the lowest we've been in 5 weeks for cancer referrals. Gynecology is just an example. The pathway has seen an increase, but in 40 to 50% of referrals in the last 5 weeks. So that's almost dealing with double the workload. But we do have opportunities within the system. We've now just become an ICB, so this will allow us to work more collaboratively towards improving the care and improving discharge and pathway flows, etc. So hopefully that will improve things, and we're really positive about the change. There's a further vaccine rollout in September, which we hope will stop any further waves in the winter, which is when we tend to see the biggest demand on the system. We've got an increased health and wellbeing offer for the staff to hopefully make it a better place to work. At the moment, it's a difficult and challenged place across all the NHS, not just here in Lincolnshire for staff. We've put in place alternative pathways for low-risk patients. One example of that this year is the breast pain pathway. Patients presenting with breast pain alone is not a symptom of cancer. However, they were coming in a cancer referral, and it was the wrong thing to do, clearly, but lots of places nationally still do this. We have set up clinics in the community to deal with that flow of this group of patients, and it's proved very popular. They don't have to undergo the diagnostics. They don't have to undergo the fear of being on a cancer pathway. They're reassured that actually what the breast pain is not a sign of cancer, and that's really helped to take away the pressure from the breast pain pathway. And that's just one example of some of the work we've done. We've also rolled out a new simulation tool. The first phase of that should be ready by the end of this week. That will give us more grip than we've ever had on the predicted impact of demand and the impact of improvements. For example, if we were to pop a new doctor into the system, what impact that would have on the performance and how quickly that would help us to recover. I'm just going to give you a very quick overview of some of the improvements that we've made at each of the individual trusts. Down at NWAF, they've implemented a neck lump clinic, so that means that patients will go to clinics often in the community. They will have an ultrasound and a biopsy on the same day, and they should get the results within 7 to 10 days. So that would mean they're either diagnosed with a cancer or step down from the cancer pathway really quickly. So that's a really positive step, and something we really applaud them for, given the pressures we have with providing ultrasound at the moment across the NHS. They've also implemented a transperineal biopsy under local anaesthetic. So this is a huge improvement for people that have prostate or potential prostate cancer. Previous biopsies, they would just take random biopsies. Now they use multi-parameter MRI, and they can target the biopsy using this type of equipment. So it's really great, and it means that less cancers are being missed. They've also rolled out a rapid diagnostic virtual assessment service. So that means that, patients that that don't fit in a specific pathway, for instance. They don't have, for instance, they've got weight loss, but they don't have any other symptoms that fit them into, say, for instance, a colorectal pathway, or a GP has a hunch about the patient having cancer, but nothing more. GPs can refer into this service, and the patient will be dealt with by specialists in secondary care. And this avoids patients being bounced around the system into different tumour sites while they try and find a specific cancer, and it means they're getting diagnosed rapidly. NWAFT have also rolled out the phase 1 of the Gallery trial, so that's a new blood test to see if it can help us detect cancer early. That was a really positive trial, and it's something we're looking forward to phase 2 of. They've brought in additional clinical support for skin pathways and endoscopy. This is because they know that they can't, they're struggling to recruit, so they've brought in additional support from outside the region. It's really, really positive, and a reduced waiting list significantly. And they've also put in place a robust cancer recovery plan, which they didn't have pre-COVID, and that allows us to have much more oversight of what's going on and what the priority areas are. This is the improvements we've had at NLAG. During COVID, they've actually brought in a dedicated cancer transformation team, which is great, because those on the ground that are delivering business as usual don't have the capacity to implement change, which is really needed at the moment in the NHS. They're now developing service improvement plans again, which will give us really good oversight of what's going on, and it'll give them a really good direction of where they need to be. They'll be implementing the best practice time pathways in lung, upper GI and head and neck for the 28-day faster diagnosis. So that will improve outcomes and for patients. They've also implemented a lower gastrointestinal rapid diagnostics pathway. So that means patients go directly to diagnostics instead of an outpatient to get, again, a rapid diagnosis of cancer or not, hopefully. They've also implemented a non-site specific pathway. Again, we spoke about that for NWAF. It's where a patient maybe doesn't have specific symptoms. So that was implemented in May, and we're just waiting for the first round of feedback after the first 3 months. They've also implemented single MDTs across the Humber, so that's working with Hull. So that's really great. It means patients are getting treated equally and getting treatment in the correct order. So that's fantastic. They've also recruited a number of cancer nurse specialists. Now, these nurse specialists cannot be undervalued in any way. The level of support they provide to patients is amazing, and the feedback we've had from patients has been great. In times like now, when we have delays for diagnostics and delays in treatment, etc., they really, really provide a vital role to the patient, provide the support, and on the end of the phone to answer questions for the patients. And lastly, just the improvements for United Lincolnshire Hospital Trust. They implemented the non-site specific pathway back in July. So they've had 136 referrals. So that was 136 patients that the GP thought could have cancer, but did not fit the mould for any specific tumour site. 7 of those patients have been diagnosed with a cancer, and 54 have been rerouted to elective care pathways. Another huge positive for Lincolnshire was the purchase of the surgical robot in January of this year. Previously, patients had to travel to Leicester for prostate surgery and waited 3 to 4 months for that. But the number of patients travelling from Lincolnshire has grown over the years, and we decided that we would try our utmost to put together a business case for a surgical robot, and that was accepted. So that's a huge achievement for Lincolnshire, and will hopefully draw more urological consultants to the area. So that's great. We have undertaken the best practice time pathway analysis. So that's those 4 pathways to help us meet the 28-day faster diagnosis standard. We know where we need to make the changes across those 4 key tumour sites, and we'll do the remainder of the tumour sites once we have done those 4 key areas. We've just completed the Gallery trial, phase 1. We had, here in Lincolnshire, we had 26 signals of cancer origin. So that means the blood test picked up a potential cancer. So far, we've confirmed 7 of those as a cancer. Those were patients that were not displaying any symptoms whatsoever. So that's really, really exciting for the future. I've already mentioned that we've developed the simulation tool to help us with the backlogs and predict what interventions will help. We've recruited to roles to improve performance utilising the SDF funding, so that's the system funding that we're given from the Cancer Alliance. We've recruited doctors, nurses and navigators who really help provide the admin support to the clinical teams. We've increased cervical screening uptake by 8% using a video text trial. So that's something we want to roll out across the wider community. They've implemented what's known as the 90-minute standard. So as soon as a patient is a doctor, consultant in the hospital has reviewed a patient's notes and can say they do not have a cancer, the patient will be notified within 90 minutes that they do not have a cancer. I've already mentioned the breast pain pathway, and we've also rolled out spot clinics in the community. So this means that patients do not have to come into acute care to have lesions, etc. looked at, and hopefully they can be discharged in the community without fear of thinking that they may have a cancer. Briefly, I'll just go into some of the future work that we're going to look at. As I mentioned at the beginning of the presentation, colorectal is a huge concern for us and all trusts. And it's not just locally, this is something that's regionally and nationally. So we are looking into a deep dive with the Cancer Alliance and our lead lower GI consultant for the East Midlands as well. So that's a system-wide process to understand the issues and work together to fix them. We're going to implement all the best practice time pathways, as I've mentioned, across all the tumour sites. We've recruited a cancer support manager to work with primary care, to work with education with GPs and those that work in GP practices to recognise early signs and symptoms of cancer. We'll work locally and regionally to roll out initiatives to support early diagnosis to improve survival rates. That's things like the cervical screening text messaging project that I discussed earlier. We're looking forward to the Gallery trial phase 2, and we're also on the list to be a targeted lung health check area, hopefully next year. So that will mean that patients who meet a certain criteria will be given a telephone triage. Out of that telephone triage, if they're classed as high risk, they will be asked to come for a CT to check to see if there's any signs of lung cancer. Lastly, I would just like to show you a very short video. This video is from our Cancer Summit that we had last month. This showcased all the improvement work and all the good things that are going on in Lincolnshire with regards to cancer. It was organised mainly by Cathy McPeak, who will introduce the next part of the presentation to you. Thank you.
Challenges that we face across Lincolnshire at the moment are the delays to patients being treated, and we're working to try and mitigate some of those delays by putting in place interventions and working with the trust to allow us to understand where there are issues and how we can improve the flow of patients through the hospitals to get their treatment as quickly as they possibly can.
Opportunity I think we have locally is how the integrated care system will essentially drive a lot of the changes.
So I try to remind myself that success isn't just about cure. It's about minimising acute and long-term side effects. It's about breaking bad news well. It's about building trust with patients and their families and helping them understand their condition well enough that they can make the decision that's right for them.
Thank you for watching that. I'm now going to hand you over to Kathy McPeak.
Thank you. I'll ask you to move the slides on for me, Sarah, if you will. So hello, everyone. My name's Kathy McPeak, and I'm Macmillan Living with Cancer Programme Manager for Lincolnshire. So before I go on to the main part of the presentation, I'd like to give you an overview of our programme. When a person receives a cancer diagnosis, it's not just their physical health which is impacted. It's a profound experience which can affect their mental health, their finances, their housing, their ability to work and to do the things that they previously enjoyed doing. And it can exacerbate loneliness and isolation and feelings of helplessness, amongst many other things. Not only does it affect them, it can also have a huge impact on those caring for them and their families and loved ones also. The Living with Cancer programme was established in 2016 to improve holistic support for people before, during and after a cancer diagnosis and treatment. The programme currently is largely funded by Macmillan Cancer Support, with small amounts of funding coming from the East Midlands Cancer Alliance and Health Education England. The deliverables of the programme are set by NHS England, but we're given local choice on how we approach meeting these. In Lincolnshire, before we decided to approach the approach that we were going to take, we listened to people living with cancer and the people that care for them to find out what the current experience is and what it should be. We were told that the major challenges for people to live well after a cancer diagnosis are information sharing, pathways not joined up, non-integration of services, a workforce under pressure, poor conversations and communications, lack of access to information, advice and support, lack of support services, and inequity around the county. So with this knowledge, the approach that we are taking can be described as: we want to create a new, better and sustainable future for supporting people living with cancer, involving and integrating all relevant parts of the health and social care system, using the assets we already have, supporting people in the place that they would like and in the way that they would like, and placing people at the centre of everything that we do. So our NHS deliverables. Our first deliverable is that by March 2023, we implement 7 personalised follow-up pathways, which we call PFUP, in breast, prostate, colorectal, endometrial, thyroid, lymphoma and skin, including remote monitoring. Now, the benefits of this are that we will see a reduction in the need for repeatedly bringing low-risk patients back into hospital to be monitored. It aims to reduce unnecessary visits to hospital and potentially frees up outpatient appointments at the front end of pathways. We ensure that safety netting is in place for all remotely monitored patients. It supports people living with cancer to actively self-manage by understanding their holistic needs and appropriately supporting them to meet those needs. It ensures end-of-treatment summaries are completed in a consistent way and are available to patients' primary care teams. Our current status on this deliverable is we've implemented PFUP in our first 4 priority tumour pathways of breast, prostate, colorectal and endometrial, and we're continuing to work with teams to ensure that PFUP is carried out to an excellent standard. We're in the process of setting up steering groups for our next 3 priority pathways. We're working with existing clinical nursing, radiotherapy, chemotherapy and care coordination teams in ULHT to ensure that holistic needs assessments, care plans and end-of-treatment summaries are carried out. We've supported the establishment of Next Steps clinics in breast and prostate, and we've implemented Somerset Cancer Register remote monitoring modules and provided training for staff. Next slide, please, Sarah. Our next deliverable is that by March 2023, we implement the 4 Living with Cancer elements. These are a holistic needs assessment and personalised care and support planning, end of treatment summary, cancer care review, and access to health and wellbeing interventions. The benefits of this are that patients are supported to live well after a cancer diagnosis, whatever the next step is. Patients are supported actively to self-manage in the place and in the way that makes sense to their lives. It ensures that GPs have access to the details of patients' treatments to aid ongoing support. and that GPs and primary care teams are encouraged and supported to improve the quality of cancer care reviews. There's an improvement in the ease of access to health and wellbeing, information, advice and support services for patients and for those people caring for them. Our current status on this deliverable is we're working collaboratively with and have provided training to clinicians and staff groups within ULHT and primary care in the community to effectively carry out quality holistic needs assessments and cancer care reviews. We've started working with neighbouring trusts to improve support for Lincolnshire residents who are treated out of county. We've integrated Macmillan Community Cancer Care Coordinators with all neighbourhood working teams in the county. We've focused on psychological and emotional support and physical activity as the first health and wellbeing elements. We've developed bespoke courses to meet the needs of our communities, for example, Fighting Fit in Lincoln and Mablethorpe, and we've made available level 4 cancer rehab training to further improve coverage around the county. With our Living with Cancer co-production group, we've developed the Cancer How You Feeling course, which is delivered by the Recovery College. We've mapped 958 Lincolnshire community assets so far, which will appear on local and national websites. And we launched the Lincolnshire Cancer Support website on the 23rd of June 2022. Next slide, please, Sarah. Our third deliverable is to address the findings of the National Cancer Patients Experience Survey and the Under 16 Cancer Patient Experience Survey. The benefit of this is that we can use each year report to improve the experience of cancer patients who have been inpatients in ULHT. We can identify particular focus of our future work, and we can ensure that our work year on year is improving the experience of cancer patients. Our current status is that we've analysed the results of the 2020 survey, which were available early in 2021. We've developed an action plan with ULHT to address areas of particular concern, and we've cross-referenced this action plan with our work to ensure that our areas of focus are correct. Our final NHS deliverable is to address the findings of the Cancer Quality of Life Survey. And the benefit of this is that using each year report, we can improve the quality of life of cancer patients who have had a cancer diagnosis in the last 18 months. Again, we can use this to identify particular focuses of future work and ensure that our work year on year is improving the quality of life for cancer patients. The results of this survey at the moment are at Cancer Alliance level, so at regional level. So this year we'll be promoting the uptake of the Quality of Life survey only. The current uptake is 48%, and we would like to increase this to 50%. When results are available at trust level, then we will be using the results of this survey more widely. Next slide, please, Sarah. Finally, we have enabler work streams which ensure that we're able to meet our deliverables. Amongst much other work, we've developed and are delivering the Lincolnshire Living with Cancer strategies and digital and workforce development strategies. We've commissioned a formative evaluation to understand the changes brought about by the programme. We use quantitative and qualitative data to measure impact. We've established and supported 2 co-production groups in Sleaford and Mablethorpe, and in collaboration with ULHT, we've established the Lincolnshire Cancer Patient Panel. Next slide, please, Sarah. The biggest risk to our programme is the fragility of our funding. Our Macmillan funding will come to an end on the 30th of April 2023. So we're currently developing a business case to request funding from the ICB for 7 roles to continue delivering the Living with Cancer programme. Thank you very much.
Thank you for your presentation. I've got Councillor Allen first, please, with questions.
Sorry, Chairman. The questions is the difficult bit. I'd like to thank the presenters for providing a transparent report that shows the situation, I think. And that is helpful, I think, to Scrutiny Committee in terms of understanding what the issues are and understanding what is going to be done to address those issues. It does seem to me that as we normally find at this committee, the National Health Service across the UK is no such thing, because quite clearly the various measures that have been used in the report to show how Lincolnshire is performing shows that there is a significant degree of success and action that's taken across the various trusts across the whole of the UK. And I would put the whole of the UK in context in terms of Europe, because I believe that we are way at the bottom of Europe anyway in terms of dealing with cancer and having successful cancer survival rates. Whilst it is very transparent in terms of what it shows, it is also quite depressing, I think, to see where Lincolnshire is in relation to the situation, and it's also quite depressing, I think, to find how much variation there is locally, with the UHLT performing so much worse than other local groups nearby, local trusts nearby. And the figures, I think, that were put forward in terms of number of people waiting for quite significant numbers of days for assessment and treatment, I think is quite worrying. You know, if you're waiting for over 60 days for some form of assessment, or even 104 days, it strikes me that, you know, fundamentally your assessment when it actually comes is very much a question of moving into the pathways that have been put forward by Cathy at Macmillan, you know, in terms of living with cancer and having a reasonable last year or so or 2 years of life. The difficulty I find is that there doesn't seem to be really anything. Well, there's let me put it in context first of all. It does seem to me that the management overall of cancer and its assessments and treatments seems to be spread across so many people, so many different parts of the organisation, that it doesn't seem to me that anybody has got overall responsibility in Lincolnshire, or even within the trust in Lincolnshire, actually dealing with the various issues. The backlogs are quite significant, obviously because of COVID, but we're still, you know, there's still a lot of talk about how things are going to improve, and how we're going to deal with the increased demand post-COVID, but I'm not totally sure that UHLT, never mind the NHS as a whole, is operating post-COVID. It strikes me that, you know, there's still elements of COVID still taking place in the NHS that aren't actually causing the sort of problems in the NHS elsewhere in the country and in the economy, where you know, quite clearly organisations are having to live with COVID and are operating in a fairly pre-COVID sort of situation. So I do worry about whether the backlog is actually going to be addressed, and what is even more worrying is that I do feel there's probably a lot of backlog that is not even known at the moment, because people are probably suffering from cancer and probably are still not getting in to see the primary care sector part of it to even enter the various pathways that might be available. And I don't see anything significant in terms of what's been put forward by the trusts in Lincolnshire about actually addressing those issues. There's lots of little bits at the side that seem to be doing things, but it does strike me that the backlog won't be addressed until resources are significantly increased, and I accept the problems associated with that, and we get more people put through because there are more resources to actually deal with that. And the only positive nature I found in this fairly depressing report is from Cathy at Macmillan, where they did seem to have some significant targets and improvements that they wanted to see introduced within the trusts to actually start moving into an improved situation, although my worry is that that's an improved situation for people that have got significant levels of cancer at the moment, and it's seeing them through, through the remaining periods of their life, rather than actually finding the early diagnosis that's required to actually identify the cancers and actually address those injuries so that people have got a reasonable period of remaining life associated with it. So I'm afraid I don't see anything significantly changing in what's been put forward, unless some of the significant challenges are actually addressed. And the most significant challenge, in my view, is resources. And I don't see an awful lot there about how they're going to improve resources and what sort of time period is going to be required to do that, and what happens in the meantime until we actually get to that situation. If somebody said to me, we're going to use all the money that we've got at the moment that's been given to effectively put people through the private sector, and we'll buy in the private sector to actually do that, I would perhaps have some more understanding of what the actual process is that's being put forward than what we have here at the moment, Chairman.
Thank you. If you'd like to try and unpick some of what was put from Councillor Allen there, please.
I'm happy to address that. I appreciate your concerns. We have the same concerns about workforce. We appreciate that as not just a local issue, it's a national issue. And when we talk about resource, that's our biggest concern. So that's not something that's being ignored. We are constantly in a recruitment drive. Also, patients, what you spoke about was United Lincolnshire Hospital Trust. You didn't think that backlog was going to get any better. I stated those figures were from May and things had got better. In fact, what our target is that we've been set by NHS England is and United Lincolnshire Hospital Trust is to get down to 151 patients by the end of March 23. Currently, we are below trajectory, so we're actually overperforming. So, and that's been a constant for the last 3 or 4 weeks, given the pressures that have been going on in the trust. I think that's a great achievement. So they are actually below trajectory. So we're on target to meet that 151 patients by the end of March 23. Of the backlog, 60% of that backlog is in colorectal. So I mentioned the deep dive into colorectal, and you said about also we weren't able to predict what would improve the situation, which is why we have we're building this simulation tool, which has been recognised regionally as an excellent piece of work. It's given us more grip than ever before to be able to predict exactly what we will need to improve in terms of resource. So we can actually put in, you can go down to the minute detail of putting in a clinic with 12 additional slots, and you can predict exactly what impact that will have throughout the pathway, how that will impact the patient's next steps. Say, for instance, an endoscopy, what type of backlog is that going to cause an endoscopy? And it goes throughout the whole pathway. So we are able to measure the impact of the interventions using that model. And the focus on colorectal at the moment is significant. As I say, we mentioned the deep dive. We've already undertaken one level of the deep dive, and we've highlighted 3 key areas that we want to work on out of that. And there's the work going on across the system to improve that. So I do think there is certainly improvements being made. With regards to your comments about management across the trust, each tumour site, so colorectal, urology, etc., take ultimate responsibility for their own cancer care, and that's right that they do so they can manage it at that level, but they have the support of the wider system. They have the SRO, Colin Farquharson, who has full oversight. So I do think there are many improvements being made in cancer, and we are on the right trajectory. In the last 3 or 4 weeks has actually been really positive for us to see that trajectory to continue to take a downwards turn towards the 151 patients that we've been asked to work towards at the end of March. And I can see Claire wants to come in, so I'm going to let her come in.
Sarah Jane, I think just a couple of other points to unpick. So I don't want you to go away with the slide that's got the details around ULHT, NWAFT and NLAG. That's just Lincolnshire patients at those trusts. So you will see a bigger proportion at ULHT because the majority of patients that go to ULHT are Lincolnshire patients. The majority of patients that go to NWAFT are not Lincolnshire patients. We're a very small percentage. So if you saw the total number for those providers, you'd see a much bigger position. But what we're giving you is Lincolnshire's population and where they go. So hopefully that gives you some assurance. I know if you saw those figures in totality, it's not an outlier in terms of ULHT. I think just on some of the another important fact is that 90% of people that do go into a cancer pathway don't have cancer. So they will come off the pathway. So whilst again you're seeing significant numbers coming in, we will see a lot of those that will come off the pathway, which is why that new faster diagnosis standard is really, really important, so that we can make some changes. And we are seeing progress against that, despite that being a new standard. I think Sarah Jane's covered the overall, so obviously Colin does have oversight of the entire system. Equally within the ICB, I have oversight of system delivery. So there are people both at system level, but also within individual provider trusts that have responsibility. Your point about unknown referrals, so we're seeing now that levels of referrals, and Sarah Jane mentioned this, into cancer pathways are above pandemic. I think we're about 120% of where we were pre-pandemic. So, but you're absolutely right, there will be people that won't have come forward, and some of those will come forward onto these pathways through an emergency presentation because of the pandemic. So those facilities have been open throughout the pandemic, but we know that we know people have refused surgery during the pandemic because they've been too nervous to come in. So working really closely with those patients is what's really important, to reassure them that it's safe to come in. And just in terms of COVID, you mentioned you weren't sure what ULHT are doing around infection prevention control, and we can get you a fuller answer from the trust on that. But all trusts are now responding to national guidance around infection prevention control and what they can do in their departments with social distancing, mask wearing, etc. Clearly, with the current wave of COVID at the moment, mask wearing has been brought back in, and we are being really careful about that. But there is an agreed, it's a national living with COVID strategy that the trusts are adopting in relation to that as well. So hopefully between us, we've covered all of your points there. And I think the final thing I would say is there is no silver bullet on this. So I think if you're expecting to see that, there isn't. This is a really difficult situation that we're in, but hopefully, I'd like to reassure you there are significant improvements being made. The trajectory for those is set nationally. There's a big focus nationally around cancer strategy as well. So, it's not just locally that we're trying to do that, across the country we are, but there isn't a silver bullet to those. Money isn't the answer. Workforce challenges are really, really difficult, along with the situation that we find ourselves in post-pandemic.
Thank you, Chairman. I don't think the comments that I've heard, subsequent to my initial comments, have altered my view at all. I just do not think that the issues that face us have been identified properly and have been assessed in terms of where that's going to leave us. Saying that we're going to deal with the 130 and ULHT is performing particularly badly compared to other local trusts, never mind the national situation. But saying that we're going to be tackling the backlogs of 139 people and 516 people strikes me as just not sensible, because people will be coming into the situation, as people come off it. It's not a question of knocking 139 off all at one go, because people will be coming into the system. And adding to those figures as people do luckily get moved off them. I'm particularly concerned that there is a primary care course to the situation in terms of identifying people that should be assessed and treated very early in hospital, and that's not happening. And we know from experience, I think, as the longer we leave it, the more difficult it gets to deal with these sort of situations. I hear what they say about lots of things happening that we're going to improve the situation. Can I suggest that we have another report exactly the same as this in 6 months' time, and they can show us that these figures have changed, and that we're no longer at the bottom of the list nationally or even locally in terms of how we're actually performing, Chairman?
Thank you, Councillor Allen. It's already listed down in my notes that we'll look at it again in 6 months anyway, so that'll certainly be picked up on. I am just conscious that I've got 7 other speakers that want to raise questions. We are now incredibly far behind, so please ensure the questions are succinct and concise. Councillor White, please.
Yes, thank you. I also note the below average performance for the 62 days and for the 28 days. One statistic is missing, and that is the time between when the patient first presents themselves to the GP and when they get a referral to specialist oncology treatment. often they get there when it's too late for the oncology department to do much about it. And I think in the past there has been pressure on GPs not to refer to hospital. I remember a clinical commissioning group objective several years ago was to reduce referrals to hospital. And there's also the fact that GPs seem reluctant to use, for example, the test that's available for prostate cancer, citing it as being unreliable. So I think there are several factors that add to this problem.
Do you want me to come in with that? With regards to attendance at primary care, there is anecdotal evidence that patients are not being seen face-to-face, but certainly there's no evidence to suggest that patients are unable to see their GP. As Claire's already alluded to, the fact is that some patients are reluctant to come forward. However, if we look at an average number of referrals over the last 2.5 years, we've certainly made up for the referrals that we've lost during the pandemic. And in fact, we've seen a significant increase, and it's continuing to increase beyond what we would have ever expected our demand to be. With regards to there's no measure from GP to oncology treatment. That 62-day performance does exactly that. It measures the point from when you're referred from your GP to the point when you receive treatment. Now, that 62-day performance is going to remain poor until we reduce the backlog because of those patients that have already gone over the 62-day performance. With regards to, I think you're talking about measuring PSA with regards to prostate cancer. That's not a test that's often done unless you've got symptoms. So it's not used as, it's certainly not used as a screening tool. But if patients do have symptoms for that linked to prostate cancer, our referral forms stipulate that a PSA blood test must come along with that. So I certainly don't have any evidence to suggest that that is not being used in primary care.
Sorry, I'd just like to say that the question I asked was not about, the question I asked was about the length of time, because we have anecdotal evidence that people are going to GPs for a long period of time before they're referred. And the problem with prostate cancer is this is all that's available to people, the test, the PSA.
As I've said, there's no evidence to suggest that the PSA is not being checked. For anybody that's got symptoms of prostate cancer, it's something that we ask to be done at the GP. So those tests are being undertaken. If you've got any evidence to suggest otherwise, please, we would welcome that evidence. With regards to patients not being referred in by the GP, the increase in referral rates is telling us otherwise. Our what we call our conversion rate, so the number of patients being referred that then become a cancer, those conversion rates have held, so they haven't dropped, and they're in line with the national levels. So it doesn't indicate that patients are not being referred in by GPs. There's also a piece of work that we undertake as a team on health inequalities. We work closely with our health inequalities team to measure emergency presentations of cancer and to try and understand the history behind those patients who have presented as an emergency, to understand if actually they did present at their GPs several times. And GPs are required to actually undertake audits, etc., to look at these patients to see if there has been an issue, and have they actually been a blocker to that patient being referred into secondary care.
I'll let somebody else carry on. Thank you.
Okay, thank you, Councillor White. In fairness, you know, I would completely agree on what you were saying. You know, I'm certainly hearing from residents on a very regular basis you can't get to see a GP. I've had first-hand experience for the last 4 weeks. I haven't been able to get an appointment. So I think there's much, much more that will come out in the wash eventually when our GPs remember that they should be front-facing. Okay, we'll move on to Councillor Chalmers, please.
Thank you. What I have to say kind of coincides with what everybody else has said so far, with people not being able to see or access a GP and then being referred. More people are coming in with stage 2, stage 3 cancer, and that's going to have obviously a more negative impact on their survival rate. In terms of clearing this 62 and 28 day backlog, what are the likes of Surrey Heartlands Healthcare doing that we're not? I'd like to see that as a comparison, please.
It's not, we tend to, when we benchmark, we're often benchmarked against similar trusts that have similar geography, etc. So it's not a trust that we have looked at as to benchmark ourselves against. It's certainly something we can look at, and we are often, last week alone, I had 3 meetings with different trusts to try and learn what they were doing on separate pathways, etc. To understand what we're doing differently. But as I think we've stated before, our biggest challenge here in Lincolnshire is workforce. And you know, we can make certain improvements, but until we actually have the workforce, which, as Claire has said, there's no silver bullet to fix it. I don't think that we're going to be able to, we couldn't stand up to trusts, for instance, that are in, I guess, Nottingham, for instance, that, you know, a bigger city with more opportunity, etc. With regards to staging of cancers, the data comes 2 years after, so it's not something that we're aware of at the moment. We do expect to see changes in staging, but there's no evidence as of yet around the staging, and that will be, let's say, it's 2 years behind normally before it's actually released nationally.
Yeah, well, I would like to see that comparison between United Lincolnshire and Surrey Heartlands, because they are winning, they're the top, so what are they doing that we're not? And then we can look at working towards how they're improving. Thank you.
Thank you, Councillor Chalmers. We'll certainly note it for when we do have an update in the 6 months' time, so thank you. Councillor Parkin, you're up next, please.
Yeah, I wanted to ask exactly the same point, that difference between areas that are higher up than we are. Can I just say that, you know, in terms of the tone, I recognise the challenges and I recognise the concern in the room, but I think we need to recognise the dedication and not question the abilities of anybody who is giving evidence today. And I want to thank them again for contributing in what must be an incredibly difficult time for them professionally as well. And I think we're in that perfect storm where if we're not careful, if people don't feel affirmed, if they don't feel welcomed, if they don't feel validated, then we then end up with the worst position of people then leaving our skilled, our talented people who we do have going. And I think we should recognise the efforts of everybody in the whole area, whether it be front-facing staff or people behind trying to get the strategies and the policies right, because I wouldn't sign up to do it. And I think we're in massive difficulty, both locally and nationally. I think GP access is massive. I am concerned that people just are not picking up the phone. I am aware of people who are just given up on the system, and so they may not even be presenting as a problem. We may not have the evidence because people just aren't calling. I have heard this week, and I won't discuss it publicly because what I've been told is confidential, and it will remain as such, but really concerning practices in some ways that GPs are working. Very concerning, and we need to probe into that more, I think, Carl. And that front door is just so important to all of this, and obviously that sits in front of what these good people here today are doing. It's the vital first step. The other thing that I'm worried about, and I couldn't glean anything about in the report, and it's sadly for me from a personal kind of perspective in terms of relative, is that we're talking very much about primary cancers. I am really concerned about some delays in people who are going with secondary cancer, particularly breast cancer, when it has then spread to bones, and GPs not being aware of the signs and symptoms of that, symptoms being dismissed as muscular or whatever, rather than people then being put into the system quickly enough. So just interested in kind of what awareness raising is going on with GPs about those secondary signs as well.
As I mentioned during my presentation, we now have very new into post a cancer project manager that's going to focus on primary care and the education within primary care. The secondary breast cancer is not something that has been raised as an issue, but we'd more than welcome if you want to get in touch with us to discuss that, and we can certainly raise awareness, and we go out into the GP practice. The idea is to go out and educate. So that's certainly something we can look at doing. With regards to the front door, we're seeing the demand is just huge on GPs. I appreciate that people feel that they can't be seen, but they are working very, very long hours, and they are doing a lot of hard work. But any particular practices that you've identified as being an issue, please also make us aware of them. We can't help unless we know those practices in particular. And just to say thank you very much for appreciating what we do. It is a very tough space, and that's one of the things that we're very conscious of. Is recently the media during COVID were very positive towards the NHS, but actually recently they've turned against the NHS, and that's very difficult for staff who are working relentlessly to try and make a difference. People don't go into the NHS not to make a difference to patients' lives, so it's really tough when they get real negative feedback when they're working really, really hard. So thank you.
Okay, thank you. I've got Councillor Rayworton next, please.
Thank you, Mr. Chairman. I'm interested in the surgical robot, Mr. Chairman. I wonder if you could tell me, since it's been used, has it been a success? I understand the cost was over £3 million. And if it's been a success, will there be another one being purchased as well? Thank you.
At the moment, there aren't plans to buy another one. It has been a success. I don't think we could argue that we have the demand for it at the moment to buy a second robot. It's currently being used, I believe, 2 to 3 days a week. Now that it's initially being used in urology, the colorectal surgeons are currently training up to use that, and the hope is that the gynecological surgeons will then also train up to use that. Robots are under what we call specialised commissioning. So actually the only specialised commissioning service to use robots is actually the urology service. However, we recognise that it is positive for the patients to be able to access that type of surgery. It improves their outcomes. That means they can get back to their normal life much more quickly. So at the moment there aren't any plans, but if demand does increase, and it has been a success for sure, then I can't see why they wouldn't consider a second robot.
Thank you, Chairman.
Thank you, Councillor Wotton. We've got Councillor Cleaver next.
Thank you, Chairman. I noticed that you mentioned that there were challenges in working with the North West Anglia Foundation Trust. 2 points on that. I'm conscious that there is an issue with mobile breast cancer screening units, which used to be provided by NWAFT, and that service has been reduced. Are you challenging them to bring that back for the people who are living in the south of Lincolnshire? And that actually raises the issue, because I didn't see any mention of such units in your report, and wonder what your view is of providing those, given the rurality of our county. And also, the Living with Cancer campaign, how does that work with NWAFT? Is there any issues there in terms of implementing the programme that you've got, which looks very impressive, again, in the NWAFT area? And slightly unrelated, could you just explain exactly what remote monitoring of patients consists of? How is that done? Thank you.
I'll take the first few questions, if that's okay. When I said about issues with NWAFT, in terms of communication, we have no issues with NWAFT. They're very open and welcoming to us as an ICB. Any meeting that we ask to attend, they allow us to attend. I get weekly reports from them. So in terms of issues, it's certainly not an issue when it comes to communication. They have difficulties within the trust, as ULHT do. One of their issues significantly is radiology. I am not fully sighted on the breast screening service, and the fact that I wasn't aware that it had actually been stopped completely. I know during COVID some of the buses were reduced that were going out, but it is, of course, it's an incredibly important service, and it must be delivered at community level. Well, we should do our utmost to continue to deliver it at community level due to the rurality of that. I don't know whether you're any further sighted on the screening. I can certainly dig into that if you're not.
Yeah, we can pick that up. We have had a discussion about screening at our council board. So screening is overseen by NHS England rather than the CCG that was and now ICB, but we have had a discussion about it at the last programme forward. Obviously, a lot of that was paused during the pandemic, so they've got significant backlogs as well. Definitely nothing was raised about NWAFT and issues in the south. There are some challenges within the rest of Lincolnshire in terms of getting around some of the rural geographies, but they are recovering that backlog position. But we can ask NHS England for an update and provide that to Simon if that would be helpful.
Okay,
Should I take over to?
Yeah.
Sorry, beg your pardon.
No, carry on. It's fine.
So to answer your first question about are there problems of working with NWAFT? No, there are no problems at the moment. What we're trying to do is in the Living with Cancer programme is to get our own house in order, in that to make support available for Lincolnshire residents. We're working, for instance, with the Macmillan Centre, the Robert Horrell Centre at Peterborough City Hospital, to make Lincolnshire residents who are getting support at the Robert Horrell Centre aware of what is available within Lincolnshire when they stop going to that support service. We would like to do more, and we are intending to do more to ensure that when holistic needs assessments are carried out within Peterborough City Hospital or within NWAFT, then those results are transmitted to our support teams in Lincolnshire and to primary care teams. But I agree there is more that we would like to do. We are building relationships with other trusts as well. So, for instance, with the Macmillan Centre at the Victoria Hospital in Kings Lynn, etc. So, but as I said, I do agree there is more that we would like to do. In answer to your second question, what is remote monitoring? After a patient's treatment on our pathways, an MDT is held, and at this MDT there is a clinical decision as to whether a patient is put on a clinically led or consultant-led follow-up pathway or a self-managed pathway. For those patients on a self-management pathway, we remotely monitor them. So we give them all the information that they need, the tests that need to be done, if appropriate, in the community. We track those patients. We let them know about signs and symptoms to look out for, and where they can refer themselves back in to hospital or to hospital teams if they have any concerns. But we would like to give people the opportunity to self-manage in the community. We do have our remote monitoring modules, which keeps tabs really on all these patients and make sure that if they are asked to have tests or whatever, those tests are carried out and the results of those tests are communicated to those people without them having to come back into hospital necessarily. We have been told that patients are being brought back into hospital to speak to their consultants or their nursing teams to be told, yes, fine, everything's okay, off you go, we'll see you again in 6 months. This is not a necessary journey, but as I said, I would like to reiterate that we do have safety netting procedures in place so that people, if they are worried, they can refer them themselves back into their nursing teams and they can continue to be supported in the hospital if that's necessary. I hope that answers your question.
Yes, thank you.
I have 2 more speakers, then I have a question myself and I'll close down the debate. So I've got Councillor Hayes first, please.
Hello. Sorry if I'm repeating myself with what's been said, because such a lot has been said. Years ago, I used to chair the Cancer Patients and Carers Forum for ULHT. I did it for over 5 years, and in those days, it was 31 days to diagnostics, and it's been reduced. I see it's been reduced to 28. The national average for that's dropped below 80%. ULHT are about 58 to 60%. So, to my mind, it's not really working. The reduction in days. Then you go on to your 62 days. You know, patient rates are now over 516 for ULHT, compared with North Links and Goole, over 190. I'd like to know why there's such a big difference between the two. My second question, you've got supporting GPs to recognise early stages of cancer. Surely GPs should be trained at the outset and gain experience through their journey as being a GP. I know of many cases, not like you said, trying to get to see a GP is difficult, but when patients go to see a GP, a lot of them are fobbed off with something else rather than say, I'll refer you for diagnostics. And that's being missed a lot. I mean, I have a relative at the moment, not round here, I admit, but in December 2020, everything was by telephone, but couldn't get to see a GP, and in the end, 5 months later, went to A&E, and when they did the diagnostics, stage 4 colon cancer, and is still fighting it really, really badly at the moment. So I would like those answered, and I'd like to say living with cancer, the cancer programme, that can only be good. Okay, thank you.
Thank you. I'd just like to say I'm sorry to hear about your relative at stage 4 cancer. It's an individual case which I don't know the circumstances of, so I obviously can't make comment, but I hope situations like that are not happening in Lincolnshire. Anything that is brought to our attention like that, we conduct what are known as harm reviews for all of these patients that reach a certain point in their pathway. Any patient that reaches 104 days has a harm review, so we do assess and understand the harm that is undertaken to patients, and thankfully at this point in time there's nobody has come to serious harm within Lincolnshire that's been on a cancer pathway. With regards to the 31-day target, the 31-day target does still exist. It's slightly different though. What the 31-day target is from the point the decision to treat a patient, what type of treatment you decide on, to the point of they receive that treatment, that's the 31-day target, and it should fit inside the overall 62-day target, and that's the only 31-day target I've ever been aware of. The 28-day target has only just been put in place in April, and we are putting in place the pathways, so that's different. There'll be different points in the pathway, so you need to have the patient's first appointment within the first 3 days, you need to have done the first diagnostic by day 10, etc. We're implementing all of that. Some of that's going to mean increases in capacity, which is not always easy. With regards to the GPs you mentioned, surely they should know that from the outset. As I'm sure you're aware, healthcare and science is always developing, so we're always learning. So these things, the new things that we learn, we need to make sure that the GPs are educated and understand what's the newest technology or the best test. For instance, the Gallery trial, last year we didn't have it in Lincolnshire, but now this year we do. So there's always developments, and that's why we educate our GPs, and we always want them to remain up to as good a standard as possible. So education is always a positive thing.
Thank you very much.
Okay, thank you. I've got Councillor Skinner, please.
Thank you, Chairman. As the previous speaker has sort of touched on, there's very few families that haven't been touched by cancer. I know my good lady some 12 years ago, I ended up insisting that she went back to the general practitioner, and it turned out to be a good hunch. Now, this report, there's been a real lot of work gone into it, and people are working really hard. There's some glimmers of hope there, but as a previous MP said, I'm not very sure at the end of reading this whether anybody's been made better. As quite rightly pointed out, this surgical robot, we haven't got a clue from this report whether it's been utilised fully or sat in a shed, to be quite honest. Development of simulation tool, well, that's really quite a good thing to be doing, but we do need to have a needs analysis to know what's actually going on in the world, and that's basic commissioning of services. The gallery tests, great, but I see a fragmented approach, and right at the end it says develop person-centred healthcare within the integrated scheme. So the report confuses me somewhat. I would like to see outcomes and not just data, meaning what does it mean to the people in the street? Thanks, Chairman.
And with regards to outcomes, generally what we do measure is we measure staging and early diagnosis when it comes to outcomes. That data is 2 years out of date. We don't get it. It's gathered nationally and it's put into a computer. It's not always straightforward. Each tumour site has different staging. So that is how we measure outcomes. There's obviously qualitative data, which was spoken about, the patient experience survey. We know that we are treating patients and patients are being treated for cancer, not being treated as quickly as we'd like and maybe not as many as we'd like, but the staff are working very, very hard on the ground to deliver the best that they can. And beyond that, I really can't see any more. We are delivering what we can when we can, and the robot is being used as much as it can. We're training more and more staff to use it. There was only one robotic surgeon when we brought it to Lincolnshire. That surgeon was previously travelling over to Leicester 2 days a week to operate on patients, which seemed ridiculous to send a surgeon all the way to Leicester and all the patients to Leicester when actually we should bring them back to Lincolnshire. And actually the robot alone, even if it was only used 2 days a week, we would manage to stand up to a business case to bring those patients back to Lincolnshire. But it is being utilised more than that. And hopefully it will be utilised full time, the more surgeons that we do train.
Thank you for indulging me, Chairman. The point is, I believe if we're a little bit more innovative, we might actually attract more staff, and that is the clue to getting staff, if we apply innovation. And there are some glimmers of hope there. Thank you very much.
Okay, thank you. I've just got 2 questions myself, and the first is, how likely is it that you will gain the funding to secure the 7 roles to support the Living with Cancer programme? And should you not gain this, what impact will this have on the programme going forward?
I'll pick that one up, Carl, because it'll come by me. You know, you've heard today the importance of this programme. It is a really important programme, but clearly any money that we spend in the NHS would have to go through that value for money proposal. So that's what CAP is doing. I honestly don't see an issue in that going forward, because I don't think we can switch any of that work off. And in fact, with the increasing numbers of people that are now living with cancer, you know, clearly that is ever more important. So I don't think it will be an issue, but obviously we have to go through that governance process and make the case, which I'm sure will be made. And we've got really good support from wider stakeholders for that as well.
Okay, thank you. And my final question is there any data on how differences in waiting times translate into survival rates?
It's all dependent on the tumour site, and the type of cancer. Normally, a week to 2 weeks doesn't make a significant difference. We are currently working hard with United Lincolnshire Hospital Trust initially to ensure that all the clinical harm is measured appropriately and at the right stage. And we've had some detailed discussions with, although I'm a clinician by background, I'm not a cancer surgeon or cancer consultant, so I'm not the right person to make those decisions, but we've had many discussions around when the right point is to measure that harm, and it has all been done appropriately. And we don't feel that, you know, some patients have had to wait a few more weeks, sometimes a few more months, and we are measuring all those. We keep a very close eye on those patients. I say we, as in the Royal We. I don't personally, but the clinicians at ULHT, NWAFT, NLAG are monitoring those patients. And if it's an aggressive type of cancer, they will be pushed to the top of any operating list to be operated on. They do have an artificial intelligence tool at United Lincolnshire Hospital Trust, which measures alongside the clinician's input, of course, because the artificial intelligence tool doesn't know all the circumstances, but that measures the importance of where people should be placed for surgery based on the types of cancer and the biopsies, etc., that have been taken to tell us which stage the cancer's at.
Okay, thank you for that. In which case, I'm going to move to a proposal. I propose the committee records its thanks to the staff working across cancer care, that we note the information presented on the cancer care programme and the Lincolnshire Living with Cancer programme, and includes improvements in the free acute hospital trust and the importance of living with cancer programme, and that we seek a further update after a period of 6 months. Do I have a seconder for my proposal? Thank you, Councillor Allen. All those in favour, please show. Thank you. That's supported unanimously. And thank you very much to our presenters for coming today. We'll now move on to agenda item 6, the People Board Strategy. This item was circulated as part of the agenda pack on pages 45 to 122, including a PowerPoint presentation, which is in the pack. I'd like to welcome our presenter who is in attendance in person, and that's Kerry Lennon, Senior Responsible Officer for the Lincolnshire People Board. Our presenters via Teams, we have Dr. Adrian Tams, Associate Director of People for United Lincolnshire's Hospital Trust, Dr. Kevin Thomas, GP, Claire Lowe, Deputy Director of People for ULHT, Amy Beaton, Deputy Director of People for LPFT, and Samia Haybar, Associate Director of People for the Lincolnshire ICS. If I can hand over to you for about 10 to 15 minutes, just to run through the paper, as we'll take it as read, and we'll take questions at the end, please. Thank you.
Good start. Good morning, everybody. So thank you, Chair. So my name is Kerry Lennon. I'm the SRO and currently the Chair of the People Board in Lincolnshire. And helpfully, I think, I've just sat at the back for the last sort of half an hour listening to the conversation. I am here with other members of the People Board. So they are local leaders within healthcare and representing the 3 trusts, primary care and the system. So we've been asked today to update in regard to workforce challenges, as we've heard already this morning, in health in Lincolnshire. People Board strategies, what strategies do we have to meet those challenges? Maybe some early successes, and hopefully answer questions you may have this morning. So just at the outset, we do have challenges. I'm not going to sit here and say we don't have challenges. We clearly do, as do others, but in Lincolnshire we do have some particular challenges. We will only do this well in partnership, hence I have brought some colleagues with me this morning. I will talk us through the current challenges. I will take the paper as read and the PowerPoint if it's helpful to read it at your leisure. And colleagues, so I will talk us through the challenges, and colleagues, I've asked the colleagues just to briefly talk us through some of those opportunities in the programme, so we will keep within our 15 minutes, thank you. So the NHS, as you know, is the largest employer in Europe. There are well-documented and publicised staff shortages. I don't think it's a surprise to anybody. But the knock-on impact, anybody in this room who's been an employer or had a job, when vacancies, the knock-on impact on staff morale, well-being, sickness and burnout, and potentially attrition and people leaving organisations. COVID has only exacerbated those. Again, that's well-documented. It has exposed other areas such as inequalities and now a rising staff turnover, which was already a difficult scenario pre and during COVID. So in summary, the challenges are, one is we need to attract clinicians into this county. We need a sustainable pipeline of people to come into Lincolnshire and live and work, bring their families, when we school their families and they come and live and work in Lincolnshire. Otherwise, we just see a transfer of staff from organisation to organisation out of primary care into community, into acute. We are starting to see a slightly improving picture, particularly around international recruitment, although we do need to also focus on domestic recruitment. The other area of challenge is development. So in addition to needing to see people come into the county, we need to grow our own. We need a sustainable pipeline coming through the qualification system, through our colleges, universities, and this is essential, particularly in those rural and coastal areas where we do struggle to recruit and retain our staff. Primary care, we need a steady, this is the front window, this is a shop window for healthcare in any county, and we need a steady pipeline of skilled practitioners. It may look like a different model to the traditional model, and Dr. Kevin Thomas is with us this morning who can talk us through that. It might look like a different skill mix. And even with maybe a declining GP partner model, which is how we're seeing it trend in this county, the workforce to patient ratio does benchmark better than some of our comparators. I appreciate this, that's still not where it needs to be. Retention. 3 years ago, we saw a steady, even an improving picture of retaining our clinicians in Lincolnshire across health. During COVID, people remained in post. They were compelled to stay, to remain, to do what they needed to do to respond. But that has taken its toll, and we are starting to see, and you'll see in the pack, a real a difficult picture of a higher attrition rate across all areas. That again, national, regional, however, we're focused on Lincolnshire. We need to retain our people. And then finally, the last challenge, we have an ageing workforce. So a lot of those people who have left, they may have put off their retirement. We have 22% of our staff in our NHS trusts who are 55 or above. And you will be aware of those in particular pension scheme can leave at that point, and some have chosen to do so following the last 2 years. It's a very difficult scenario. Primary care replicates that. In the areas 45 plus years, we see that we're beating the national average around the age profile, and those 20 to 44 we are not. So we do need to encourage a sustainable pipeline of younger clinicians into the county, or again, grow our own. So what are we doing about it? It will be probably one of the questions. But the People Board, we are a group of people leaders in health and social care. So we do bridge across to social care, but I'm focusing purely on health today. But just to reassure that we are working very closely with adult social care colleagues. We are working collaboratively and sharing ideas, resource. COVID actually brought us together because we had a common response, and we have kept working in that way. This is the third year of the Lincolnshire People Plan, so if you want to read that at your leisure, of what we're actually, some ambitious targets in there to deliver. The colleagues on screen, I'll get out of the way and I'll ask them just to share some of the programmes that they are directly involved in, or their teams are directly involved in. And then, if that's okay, Chair, we'll open for questions after that. Thank you. I'll hand over to Claire Lowe.
You're on silence.
You think we would learn, wouldn't we? Yeah, I do apologise. Good morning. Thank you, Kerry. Good morning, Chair and members. I'd just like to talk through briefly the work that I'm leading on, which is linked to the attraction pillar within the People Plan. You'll have seen in the pack, pre-COVID, we launched a Be Lincolnshire campaign. Unfortunately, it was hindered as the pandemic hit us, but with something that we're really focusing on relaunching. It's a digital platform that we're linking in with schools, our education providers, our universities, to really sell the benefits of living in Lincolnshire, the cost of living, the exemplar educational programmes and levels of schooling that are available to really try and attract and retain talent within the Lincolnshire region. And that's work continues. We're in the process of recruiting a attraction lead that's really going to take that piece of work forward for us. So we're really excited about really relaunching that, because unfortunately, as I say, it was hindered by the pandemic. I'd just like to talk to you briefly. Sorry, I didn't introduce myself. I do apologise. I'm the Deputy Director at United Lincolnshire. The work that we're doing at United Lincolnshire to try and address our recruitment challenges, we're working very hard in terms of our traditional recruitment, but also really upping the ante in terms of our international recruitment programme. You'll see in the paper, Chair and members, that we've had a real great success in terms of recruiting international nurses, and key to our international recruitment programme is our onboarding support that we're offering these newly recruited members of staff, because it's not just about the members of staff, it's about supporting the families, finding accommodation, embedding them in cultural communities, ensuring that they have the right support, helping with costs. Often in my experience, when we recruit from overseas, there are financial challenges for members of staff coming across to the UK. So this is something that we're really proud that we're helping with. We're also working very closely with the local refugee doctor programme, and I hope that you read with interest the case study that was in the paper with regards to Dr. Mo, who had a very difficult and tenuous journey into employment, but now classes United Lincolnshire as his new family. And this is just one case study of many where they are their skill set is something that we very much want to be able to embed in part of our treating our residents and members of the community in the Lincolnshire region. Work continues with the Doctor Refugee programme and also the international recruitment programme. We're looking to scope to move into allied health professionals, and also looking at how we continue to grow that local community feel. So word of mouth is very strong, and if our international recruits feel a part of the Lincolnshire family, then that word of mouth is very strong. And we have a huge accolade of having a 99% retention rate, 100% success rate for those members of staff qualifying with their OSCE, which is the English qualifications which enable them to participate in full and full educational and clinical roles. So I don't want to take up too much time because I know my colleagues would like to share the pillars that they're also leading on. So I will pass to Amy, and thank you for your time to be able to share the great work that we're doing at the moment. Thank you.
Hi, I'm Amy Beaton. I'm the Deputy Director of People at Lincolnshire Partnership Foundation Trust. I'm just going to carry on the conversation around international recruitment from our perspective. We have currently got challenges in terms of vacancies for nursing, for our medics particularly. So we have embarked on an international recruitment campaign. However, the supply of international nurses with mental health experience is not as plentiful as general nursing. So our numbers are much smaller than what you've just heard from ULHT. This year, we embarked on a target of recruiting 37 nurses to join with us. And this included 3 refugee nurses. We have a relationship with the charity Talent Beyond Boundaries, and are looking to onboard refugee nurses as part of our programme. As I said, the mental health experience of international nurses is not as plentiful, and that also means that the training is not as well established nationally. We've had to therefore embark on designing our own training programme. We do have a 100% pass rate, so are extremely proud of the work that we've done in this space. And as a result, we feel we're in also a good position to expand our numbers. So from the recent NHS England offer to increase numbers, we are looking to increase our nurses to 50 being onboarded this year. We've also been successful in gaining GMC sponsorship, which means that we can recruit international medics and support them with getting their GMC registration when they're working with us. We have partnered with Navigo, which is the mental health social enterprise in North East Links, who have established relationships in India, and therefore we're looking to onboard a minimum of 5 international medics as well. In addition, we're recently looking to expand into allied health professionals and look for 5 international AHPs. The paper does describe that we're being held up as an organisation leading the way for international recruitment for mental health nurses. And this has been good for raising the profile of Lincolnshire and of LPFT. However, we are new to this, and so we would welcome any input or insight from others, including chair and members of this committee. But due to our reputation, we are leading on a number of work streams regionally and nationally. We are working nationally with other trusts around developing the support that can be offered to our international nurses in advance of their arrival to help them complete competency tests. And we've also been asked and funded to run an in-country campaign as part of piloting recruitment and retention methods. As part of this, we will return to the home country of our international recruits, which is in the Caribbean, and our Director of Nursing will use this opportunity to engage with government officials around what we can do to give back to these countries as well, demonstrating our commitment to being an ethical employer. That will not only raise our profile and reputation, but it's the right thing to do and what we're committed to do. Finally, we're also working with the East Mids Alliance, and we have been asked to design a train the trainer for other practice educators in other organisations, and that's part of our commitment to partnership working and sharing best practice. We will get best practice from those other organisations, and we're helping and supporting each other. I just would like to end to say the same as Claire, really. The pastoral care has been the absolute critical part in ensuring that our international nurses are integrated into our workforce. And we have spent a lot of time and resource in this space and have worked collaboratively with United Lincolnshire Hospitals around ensuring that we have programmes and activities that will integrate our nurses into the community and make them feel a part of our county and organisations. Thank you, and I will now hand over to Kevin Thomas.
Hi there. Hi everyone. I'm Kevin Thomas. I'm a GP based in Market Raisin, and I'm also a clinical director at East Lindsey Primary Care Network. And I'm here representing the Primary Care Network Alliance as the GP workforce lead. Developing a primary care strategy is much more complex than one that might be developed by trusts, because we are dealing with 85 individual organizations who are GP practices, and they are independent of each other and have their own priorities. So bringing them all together in a unified strategy is certainly much more tricky than working for an individual trust to do so. Nevertheless, we're working as a system to try to bring forward an environment which means that Lincolnshire is an attractive place to come and work as a GP, and also we look to retain these staff as well. We have a few programs which is detailed in the report, but I'll go through a few successes that we have had. So firstly, we have what's called the Targeted Enhanced Recruitment Scheme. This is a financial incentive for trainee doctors who may want to come to Lincolnshire, specifically rural Lincolnshire and areas of high deprivation. This has been very successful over the last few years that it has been running. For example, I trained in Lincolnshire and trained in Lincoln, and I qualified in 2013. And at that time, we had about 20 trainees. Since the TERS scheme, there's been an increase of about 60% of GP trainees, and we have over 45 trainees at the minute. So that has been very successful. Moving on from that, the next step is to see how we can try and retain these staff against a background of shortage of GPs. So what I would probably say is we are looking at a fellowship program which has now been running for the last year and a half. So this is a fellowship program for newly qualified GPs where we offer training, support and mentorship and help those GPs develop their careers and enable them to stay in Lincolnshire and build their skill sets up. And over the last year and a half that it's been running, and it's been run by the Lincolnshire Training Hub, we have 34 GPs enrolled into that, and we are hopeful that these GPs will continue to see the benefit of staying in Lincolnshire and continue to develop their careers here. In addition to that, as a long-term plan, we are working with the medical school. Obviously, you know that the medical school is only 3 years into its program, but we are talking to the medical school about how we ensure that medical students consider general practice as a viable career option, and also one that's rewarding We do that by ensuring that medical students have placements right from year one, and they have a good proportion of exposure to primary care right from year one. Obviously, for a third-year medical student to become a GP is another 7 years down the line, so it will be a long-term strategy for this. As you can see from our report, our GP partner numbers have gone down, and this is consistent with the national picture. Concomitantly, though, what you will have noticed is that our salaried GP numbers and other clinicians working in primary care have gone up to try to compensate for that. So overall, the total working population in primary care is higher now than it was in 2019, and we have an additional workforce, including paramedics, physiotherapists, and clinical pharmacists. Certainly, all of these staff need supervision, need extra training, and we are developing those programs for them as well, so they can all work at the top of their license. As I'm sure I don't need to tell you, we have a shortage of GPs nationally, and that's reflected in Lincolnshire. All of these programs, the aims of these are to try and bring Lincolnshire GPs into Lincolnshire, but also try and grow our own. And over the next few years, we hope to see fruit from that. Thank you.
Thank you, in which case we'll move on to questions. Got Councillor White first, please.
Yes, thank you. My local GP practice has only got one full-time GP on 8 or 9 part-time. When my husband was looking for an appointment, it came up that they were working 2 or 3 days each. So my question is, how many GPs in Lincolnshire are actually working part-time? Because I don't know whether these GPs are working part-time in my local practice and part-time somewhere else. And the second question is, has the problem been resolved about the pension pot? Because I think the taxation situation for older GPs is one of the reasons why they're retiring. Thank you.
I will start that answer, but Dr. Thomas is on the screen now, so actually, shall I hand over to you, Kevin?
Yeah, I'm happy to.
Thank you.
So I agree with you that actually a lot more GPs are working part-time, and also a lot more GPs are working in what's called portfolio careers. The old-fashioned way of working in one single practice full-time is no longer seen as the way in which GPs, or certainly newer GPs, want to work. We have in the paperwork, we have the total whole-time equivalent GPs. So for example, if we have 2 part-time GPs for Lincolnshire, they would be considered as 1 full-time GP. So it's a whole-time equivalent data that we've shared with you. The pension issue has not been resolved. I know that the BMA are still in discussions with the government about that, and I think that is a big driver of older GPs wanting retiring, and that's not been resolved for a while now.
Yeah, can I just follow that up as well? From a part-time, sometimes that is a retention tool, or it's even an attraction tool into any industry, but also clinicians. Sometimes they have part-time tutoring, lecturing, or actually they want a part-time contract. So sometimes it's an ability to retain a clinician, particularly nearing the end of their career, if they're wanting to semi-retire. So I appreciate that doesn't help from an accessibility point of view. However, that is sometimes an overt way to retain our senior clinicians, or even our clinicians coming through who want a more flexible approach to employment.
My point is that if some of these GPs are working full-time, we'd have more GPs.
Absolutely noted, yeah. Thank you.
Thank you, Councillor White. Councillor Allen.
Thank you, Chairman. I found the report, it's got lots of information in it, but not necessarily sufficient information to allow us to make reasonable comment or have a reasonable understanding of it. And the questions then are about, you know, an understanding as opposed to then going into any form of detail. The question I've got in terms of the overall figures, in terms of vacancies, and I was quite interested to see that the vacancies in Lincolnshire are not particularly worse than elsewhere. So we're not particularly hard done to in Lincolnshire. You know, we're suffering from the same sort of information, same sort of difficulties that apply nationally. But we're not particularly. We seem to be at the bottom of all the other measures, and it can't all be explained by lack of staff. There's an issue there that seems to have come out of it. The political problem I've got with it is that it's only over 2 years, so it's over the pandemic period, in terms of the overall situation, in terms of vacancies. And I appreciate this is more about, you know, new employment as opposed to the historic sort of situation that we've got in Lincolnshire. But I would have thought that we'd be looking to deal with a number of issues in terms of new employment, and one of them is to deal with the current vacancies. One of them is to deal with the backlog, and another one is to deal with the imminent tsunami of retirements that are coming into our workforce because of the demographics of the age group that we've got in the medical system. And it strikes me that there's a number, you know, that we ought to be saying we need so many posts to actually get back to where we ought to be, so many posts to deal with the backlog, and so many new posts over a period of time to deal with this imminent retirement. And without that information, I don't know what your strategy is really going to be. And so I think that's missing in terms of you know, what you're trying to actually achieve. In terms of the primary care item, I was pleased to hear that these are full-time equivalents rather than just numbers, because it is full-time equivalents that we get the coverage that we actually require in the primary care system, particularly in the GP system. And again, we do seem, as we heard from a report to the committee last time or the time before, there does seem to be significantly more resources going into primary care in terms of recruitment of, you know, practitioner nurses and specialist nurses and all that sort of thing. I would like to see some information, though, that says it's not just the numbers, it's the numbers of appointments that the system ought to be providing to the public, so the public's got a good chance of seeing either the GP or a specialist person in the practice, because all the evidence that we seem to get from people contacting us is that it is not easy to get an appointment, a face-to-face appointment. It's sometimes not easy getting a telephone appointment for what good that might be in a particular circumstance. So I was interested, you know, that within practices generally, there should be more resources and there should be more appointments going through the system. My concern is that the more and more people that the GPs hire, the less and less appointments they actually do themselves. And, you know, the appointments don't seem to be actually increasing in relation to the actual provision of resources and the cost of those resources in GP practices, and there's something that needs addressing there. Because, you know, if there's more and more money going into the GP practice, there ought to be more and more return in terms of what the patients are actually getting out of the system. And full-time equivalent from a GP point of view, be it salaried or be it a partner, has got some issues associated with it, because in my view, from what I've read, you can be full-time employed as a GP partner or full-time employed as a salary staff without necessarily doing a significant amount of patient contact or patient face-to-face appointments within the practice itself, because you can effectively contract out the partner or the locum resources into care homes to do visits and all those sorts of things there. And a lot of these meetings that take place within the NHS system seem to effectively count as full-time employment as well. So, you know, I think what's required is some figures associated with the appointments that have been provided within the recruitment and within the investment is needed, because, you know, otherwise these things are fairly pointless. You know, got lots of doctors, but not many people doing doctoring.
Thank you, thank you. So a few questions there just to pick up. So if I just take them in order that they were brought, if that's okay. So from a primary care access point of view, I'm aware that that is in a future meeting in October. So if that's okay, we'll steer away from access to primary care. I appreciate that's a real issue. However, I don't have the answers to that, unfortunately, today. However, the workforce... I absolutely will. So I'll answer your question around how do we know the numbers. So I'm going to answer that one now. And then I'm going to ask Salmia on the screen shortly to talk about what retention are we doing, what strategies are we employing to retain those who are likely to retire, because that was another question. And then I'll ask Dr. Kevin Thomas to talk about utilisation of new roles and existing roles and that mix, if that's okay. So I'll pick up the first one. Workforce modelling. How do we know? So we are just launching a workforce modelling tool we have acquired with a strategic partner, and we've had some funding to do this, and to do this as a NHS broad workforce, one workforce. And what that will do is in one place tell us, regardless of whether you work in a GP surgery, in a community trust, in the acute, what is our staffing at this moment in time. It will also tell, and you would assume we might have that information now. We don't currently have that information. As Dr. Thomas said earlier, these are 85 GP practices who have their private businesses in effect. Appreciate that might be a clumsy term, but they don't necessarily need to provide some of this information. However, the PCN Alliance is working really, really hard with practices to ensure that we have all that information to hand. We are going to have a model which is with a strategic partner which has been really well used in the Northwest, in a big NHS trust up there. So we will know at any point who we've got in employment, whole-time equivalent, the age profile, the likelihood of, from a pipeline point of view, who's likely to retire, who's coming on board, and we can predict. What we've not been able to do is predict effectively. So we will know 2 to 5 to 10 years' time, what is the staffing model going to look like? And given I'm sure you're aware of the changing nature of healthcare and more out-of-hospital provision, as we start to put that modelling into this solution, we can start to predict the nature of the workforce that we will need to look for 5 years to 10 years' time. I appreciate this is very medium to long term, doesn't support us today. We will provide the information you've asked for specifically around primary care. And I will just, if you're happy with that answer around the numbers, I'll ask Salmia to talk about retention for those retirees, please.
Thank you, Kerry. Good afternoon, everyone. My name is Salmia Hebar, and I'm the Associate Director for People for the system. And I lead on the People Hub, which is a team that's very newly formed, a new team that's been put together to really help with the delivery of some of these strategic ambitions that we have in the region with regards to people and our workforce. So specifically answering the question around retention, in 2020, the NHS launched something called the People Promise, which is a promise that they made to every member of staff that worked within the NHS, no matter where, looking at 7 elements, and to specifically address the concern around retiring individuals. Yes, we are aware that within the region, we have an increasing number of people, both medics and nurses, that are going to retire in the near future, and this number is increasing year on year over the next couple of years. And what we do towards that is within every individual provider organization, be that ULHT, LPFT, or LCHS, we work on a retire and return program. So our aim is to work with these retiring nurses, retiring doctors, and see how many of them can come back to the organization. And we're also aware that when they do look at coming back, one of the things that they ask for is flexible working. So they want to work reduced hours, they want to work, so doctors want to come back, but they don't necessarily want to do the on-call shifts. Nurses come back, but they don't necessarily want to maybe do the night shifts. So there are a number of things that we're doing to address this situation. There's also this project around being better informed. So there's no point in getting all of this information once the individual has already left the organization. So again, individual provider trusts are putting in place things called exit interviews or stay with us conversations, where there are proactive attempts to speak to people in different career brackets, just finding out from them what is important to them, so that then the organization can look at a strategy to effectively retain these people, and not just the retirement returnees, but other people as well. COVID has had a massive impact. So retention ties in very, very closely with the attraction campaign that Claire spoke about early on, because we're also finding that some people are making life-changing decisions about, relocating to other places. So it's all the more important for us to sell Lincolnshire as a region, talk about the schools, talk about the communities, encouraging these people to build homes here, and kind of integrate families here into the community so that they don't look elsewhere. The NHS provider trusts are also working a lot closer together, because again, a data point is when people, especially nurses and AHPs, leave one provider organization, they just move across the road to the other provider organization. So we're trying to work on with different staff groups to see how we can proactively help them develop by putting together rotational programs, so that it's a planned move and we are aware of how many people move from one organization to the other and are better prepared in terms of providing patient help. Thank you.
Thank you. I know you wanted to come back, Councillor Allen, but I have a question, I think, which will sort of tidy up around the edges, so to speak, that I already had down. So obviously the papers include a number of initiatives, but there are very few timescales within these. There are no KPIs or milestones that can be seen. Are there any documents that include these, so there is a bit of focus? And if so, can you share them with the committee? If not, are there plans to prepare KPIs, etc., to make it all less vague and more focused?
Thank you, Chair. I can answer that. In some areas, we do have KPIs. In all provider trusts, we have targets. We have NHS England targets. We have national local targets. And we can certainly provide that information. That I suppose, within the report, try to make it as broad within healthcare. We wouldn't necessarily hold that information across our primary care colleagues. So, yes, of course, I can share what we do have. Salmia, who's just been on screen, has recently been appointed to pull together what we're calling the People Hub. And that is to look at healthcare and adult social care, but look at healthcare as one. So we start to look at the workforce, and those milestones and KPIs will be in. So whatever we do have to hand, of course, we will provide, and we'll certainly give an indication of what that might look like 6-12 months from now, if that's okay.
That's fantastic. Thank you. I think that'll be very helpful for all committee members. I've now got Councillor Chalmers, please.
Thank you. I've got a couple of questions in two completely different directions. So my first question is, why are applicants from in the UK, so our internal applicants, why are they choosing other counties if they're looking to relocate? From what I've observed from both what you've said and from in the paperwork, you're wrapping Lincolnshire up as Lincolnshire, and in fact, if I was looking for a new home, I'd be looking at Grantham because it's got connections to Lincoln, or I'd be looking at Boston because it's cheap to have a house here, but it's got a really warm, big town but village feel. So do we have recruitment videos that actually touch on what attracts an entire family? Because I'm not seeing anything like that. The very easy way to recruit people is, why are they choosing, say, Lancashire over Lincolnshire, or what are their reasons for not looking at us? And I'm not seeing anything that addresses that. Also, we spoke about GPs and part-time GPs. Now, I actually was invited into a GP office, and they said that they had big problems with junior GPs and more, I suppose, people with 5 or 6 years experience only wanting part-time hours. Now, that I can see you've put into numbers, and 2 part-times is a full-time, blah, blah, blah. But this is going to provide us with massive problems in the future, because without the GP, the younger GP, putting the 5 days a week in, the starting early, the finishing late, and the seeing through a patient, they're going to lack experience when they hit 50, 55, because they're literally not going to be able to, they will not have seen the same amount of people, the same amount of hours, and they won't have had the same exposure to unusual disease as a doctor who is currently working full-time. Thank you.
Thank you for that. I will address the first two, then ask Dr. Kevin Thomas to address the last one, if that's okay. So, great question around parts of Lincolnshire. We're just talking about Lincolnshire as a whole. When Claire mentioned about Be Lincolnshire campaign, and so if you do choose to use the link and pop on there and have a look at that campaign, it does talk about the rurality of Lincolnshire in certain areas, talks about the coastal areas, and we asked them, so we worked with Be Lincoln, as they were at the time. I think they've just changed their name. We worked really closely with Be Lincoln, who are a destination management organisation. We need to work with the experts to understand why people aren't coming to live and work in Lincolnshire. And so they did some market research. We have that report. It's dated now. It's 4 years old, but we can share that if that's helpful. And that was to understand why. And in some areas there was an ambivalence. There was a lack of understanding about where Lincolnshire is, what might it do. We didn't necessarily have the medical school at the time. It was in formation, so some of the attraction elements. And there was a level of indifference. So there was certainly the message came from Visit Lincoln. We have got to promote the county as a place to come and live and work. And you're absolutely right around segmenting that, because different parts of the county will offer very different things. And so the report, I'm happy to make that. What they did also say is you need to target 3 particular groups. One of those groups were young families. So for the reasons, you know, at the start of people's career, whether they're a nurse, doctor, AHP, to come and live and work here, because the schooling in Lincolnshire is seen as really, you know, it's a great advertisement for Lincolnshire. And so absolutely target that group, young families. Target those who are, much as we say, most of our, well, a fifth of our workforce are 55 and above. Actually proactively target those individuals that are outside of Lincolnshire. If they're planning to come to Lincolnshire to retire, maybe they'll come to Lincolnshire for the last 10 years of their career before they retire. So actually that's a targeted market that we could target. And then the other one was looking at innovation, and I was just at the back when we were talking about robotics earlier and remote monitoring, and we have such challenges in this county around the size of the county and the transport links and the necessity to work remotely. I mean, we have people on screen today, but how do we, and we have a lot of innovation happening, and so how can we attract people to come and live and work in Lincolnshire, because we are at the forefront of some of this stuff, and we are at the forefront of some of this stuff. So that's another key area. So you're right in targeting the localities within Lincolnshire, but also targeting particular demographics to come, and that's when we refresh the Be Lincolnshire campaign. That's what it will do. I have Dr. Adrian Tams, who was going to talk about the coastal and rural transformation. I appreciate you've got the slide deck. So I'm just conscious of time, Chair. Would it be helpful for Adrian to briefly talk about the coastal and rural transformation work? And this is about training people up in those harder to reach, harder to recruit areas. Or should we take it as read that the pack is sufficient?
I think as long as it's fairly brief, because I think I've got still 5 more speakers, and I'm just conscious of we're about half an hour behind as it stands. So,
okay.
Not your fault, ours, but nevertheless, I think if it could be brief, though, I think it would be useful.
We can certainly talk. So apologies. Yes, Aid will be incredibly succinct. Thank you.
Thank you, Kerry, and good afternoon, Chair and members. I will be really succinct. So I'm Dr. Adrian Tams, Associate Director of People Planning and Transformation at ULHT, and I'd like to thank you for inviting us into the People team into committee this afternoon. So you'll have seen, as it's been set out in the Rural and Coastal Transformation paper that's been distributed, this is a programme really that evolved from my own passion and experience of living and working in Lincolnshire, and also my involvement in a 2-year all-party parliamentary inquiry into rural health and care. And it's also been developed alongside Professor Sir Chris Whitty's annual report into health in coastal communities. And I'm really proud that Lincolnshire is actually one of the 5 ICS regions in England. And we know that a combination of worsening health, ageing population, social deprivation and workforce staffing issues are really leaving a footprint in health and care services in rural and coastal areas and facing really serious challenges. And we've heard a lot about those today, really. The main ethos of the Health Education England programme that Lincolnshire is really one of those pilot sites on is to help tackle some of those health inequalities, but also it's a real enabler that will hopefully bring agencies, or plans to bring agencies, to work together to find a range of solutions to those equalities, but also through transformation of the health and care workforce in Lincolnshire. And this is initially a 12-month plan, but it does have ambitions to have a 3-year plan and wider than that. And the plan is based on global evidence, so we're not just looking at Lincolnshire, and we've not looked at only other areas within England, across England. We've gone global and brought it really down into a sense of space, and it's really to drive those health and inequalities through education, training, use of digital technology, whilst also enhancing and upskilling our workforce. So it's really aimed at and using that evidence, that global evidence by Professor Roger Strasser from New Zealand, to address the problem with attracting, recruiting and retaining a workforce in the face of that growing demand from our communities that you and I serve. And we really do want you to be included in this programme as it evolves, and it will work in tandem with those programmes that you've heard about today as well. So it's fundamentally designed on a mix of existing proven interventions that are really anchored around some of those key initiatives internationally that we can bring back into that sense of, into that place of Lincolnshire. We have the full support of HE, who've invested in a dedicated programme management officer who will work closely with us in the ICS, and that includes you and I, to utilise that existing activity. And we have some real exemplars in Lincolnshire of how we've embraced our rurality and our coastal issues through workforce and some of the innovation we're doing, but also through, for example, the medical education reform programme, the generalist doctor programme that is currently Lincolnshire's going to be a pilot for that again starting in September. And it really enables us to focus our work on ensuring trainees across the spectrum of health professions develop a broad range of skills needed for rural and coastal practice that we know are so endemic within our county. So the programme's developing solutions to secure workforce by learning from that global research, particularly the importance, and we've discussed it already today, rural upbringings, positive undergraduate clinical and educational experiences in rural settings, and targeted training for rural practice at postgraduate level. So they're developing a real skill set, and that's an attraction, and we're hoping that drives some attraction into understanding and being specialists in rural health and care. We've recognised that health inequalities in rural coastal areas are not going to improve unless we do this. And again, Lincolnshire is a beacon and a pilot site for some of this work, particularly on the East Coast, where we're facing some of those biggest challenges. And just really to finalise, the programme in Lincolnshire over the next 12 to 18, 24 months is really going to focus on 3 key areas of learning, and that's widening participation and access to our medical schools, such as at the University of Lincoln, with an ambition to increase applications from our own rural communities, introduce innovative rural and coastal healthcare apprenticeship programmes, which we're already doing. We are exemplars across a number of AHP programmes across England. And we're going to instigate initiatives focused on increasing digital and health literacy, which is really important, particularly in some of our more challenged areas around the East Coast. But that will then impact on workforce, and our workforce become digital enablers. So it's anticipated really that through that programme and through this programme that we're developing, and I'm really passionate about it, as I'm sure you can tell, we are really challenged, particularly the East Coast, and with these combined initiatives such as the Campus for Future Living, will attract a workforce who are interested in new ways of working. They'll develop new skills in rural health and care, but really most importantly for us as a people team, it's growing and retaining that talent within Lincolnshire. I hope that's covered the programme off very quickly and very succinctly for you, and I'll hand back to Kerry. Thank you, Chair and members.
Thank you, that was helpful, thank you very much. Would you like to come back, Councillor Chalmers?
Thank you very much. Yeah, just quickly, I've got quite a lot of experience in recruitment, over 20 years, and I'm listening to you, Kerry. You did your research. People were saying things like, what's Lincolnshire like? Don't really understand it. It's been identified and we could, but what I'd like to be hearing is we've listened to the feedback, we've spent the money on the research, and this is what we found and this is what we're doing about it. Also, you've spoken there about coastal areas, social deprivation. Who wants to work in a socially deprived coastal area? Me, I want to live by the seaside in a small town with a thriving community. So it's all in the deliverance and the sale. And rather than referring to our doctors as come and work in our socially deprived area at the coast, it will be cold and wet and the sees brown. What about beautiful sunny environment, a perfect place to bring up a family?
Incredibly inappropriate, but I'd love to have another conversation with you outside of this. Thank you. Absolutely agree. Absolutely agree. In the same way as we had the example of Dr. Mo, he has come to live and work in Boston. He considers Boston his home. He considers ULHT his family, and absolutely. So the Be Lincolnshire campaign, as it was mentioned earlier, we launched it in December 2020, which was probably just, it was never going to, it was a, and we have now secured funding just to continue that. So we are going to scale that up. We're also working with Lincolnshire County Council just around the broader traction, because what we experience from a recruitment and retention issue, we know our adult social care colleagues absolutely experience the same. And I'm not talking about necessarily the geography, I'm talking about the general recruitment and retention issues. So yes, we are refreshing that. I would love to have a conversation with you, but yes, we are doing that in the next 6 months. We're just engaging now with that strategic partner to do that digital campaign, and it will absolutely be, why would you want to come in? Because of what all the assets that those places have. And the videos that we currently have on Be Lincolnshire, it's called Be in Lincolnshire, I think it's in your pack. It does absolutely put Lincolnshire at its best. It shows it at its best of people who are living in those areas, who love living in those areas and working in those areas, rather than, as you suggest, that we would sell it in any other way. Thank you.
Thank you. Okay, we've got Councillor Whittington next, please.
Thanks, Mr. Chairman. I think the points I was going to make, I think you made in your contribution a few minutes ago, when you started to talk about the need for KPIs and stuff. Because I sat through the last two presentations, and what I've seen is an awful lot of strategy documents. I've seen an awful lot of sort of lists of plans and lists of initiatives and all kinds of stuff like that. What I haven't seen are action plans for delivery and how all this is going to be delivered. And I have real concerns about that, because, at the end of the day, one of the problems potentially is, and the cynic in me says, that you develop strategies, you then have to deliver them, you have to force them through, and not come back in 3 years' time and go, actually, we need a new strategy, because you've not delivered or driven through the previous strategy, because you denied any action plans or deliverables. And that was my big issue with the first paper on cancer, because I didn't see that there. I've not seen it here either. And for me, it's just a real weakness in the papers we've had this morning. There's been no stats in here. There's been no quants in here, no quantitative stuff at all, to actually give me any confidence that, because I'm an accountant, I like to see the numbers. I like to be able to see and piece it all together, in order to see, what the action plan is going to be, how we're going to deliver that, what are the KPIs, what are the timetables, what action plans, when's all this going to be delivered by? Does this come first, then that? Then I can't see that here. I see an awful lot of really fancy presentations. It's not giving me any confidence that any of these problems are going to be addressed. Thank you.
Thank you. Great question. Thank you. I apologise if that's not meeting the requirement this morning. And I can absolutely understand the councillor's concern. We have just created the People Hub. So we spent the last 3 years working. I've been the SRO for 3 years. I'm also the Director of People in LCHS and the Community Trust. So it's taken a year during COVID to build relationships. We are now, as a senior people team across Lincolnshire Health and Care, working really collaboratively, which is great. And as the councillor suggests, that's wonderful, great presentations. However, when will we see the dial shift? When we will see the numbers shift? And what's the commitment to that? So the People Hub, which is mentioned in the programme, is a delivery arm. So these people are not. So my day job is the Director of People at LCHS. A number of these people, Dr. Kevin Thomas is a GP, and we need to ensure that he has his clinical time. So these are devoted people, Salmia being one of them, heading up around the delivery of these. So that is in form at the moment, and I will make a commitment to bring that back if that's helpful to the committee, to both show the milestones but also the delivery up to that point as well. So we've hopefully shown maybe some aspects where we have a commitment to do this well, to do it together. We have some early signs of change, but it is early. It is against a backdrop of significant attrition of our staff. It is against a backdrop of rising COVID cases, as we know at the moment. So it is the perfect storm, I think, as someone mentioned earlier. However, we have a commitment to do this. So we will show you, what that commitment will be from a numbers point of view, from a stats point of view and KPIs, but also our milestone to deliver.
Okay, thank you. I've got Councillor Cleaver next.
Thank you. In relation to training of new staff, I mean, I note from your, and it's something that comes up a lot now, that we are far more dependent on direct patient care staff in primary care than GPs, and in fact Lincolnshire seems to be leading that trend. And obviously in relation to this rural and coastal transformation paper that's included, are we successful, or are we making any inroads into having opportunities for people to train as direct patient care staff on the East Coast? So they don't, young people coming into the workforce, coming into education and coming into further education and training, don't have to leave the East Coast to train up, and then might not, of course, return. And I think this is part of the holistic approach we need to the problems of deprivation on the East Coast of Lincolnshire anyway. But obviously, it would be very helpful as part of that package that needs to be put together if education for direct patient care staff and other healthcare staff is available. People don't have to travel to Lincoln. It's there for them on the doorstep. I think that would be very helpful, and I'd be interested to know what, following the transformation report, what progress is being made on that. On international recruitment, is it your opinion that the government needs to do more to ease the visa and work permit rules to make moving here more attractive for staff from overseas? And finally, just to pick up on the point from on the GP side, it's widely reported, and I see it quite often again, that there are more salaried GPs and fewer partners, and again that's a trend. Is that actually because partnerships are not offering partnerships to new incoming GPs, or for some reason are more reluctant to do so? I'd be interested to know about that, because I've not seen that answered anywhere. Thank you.
Thank you. Thank you for those questions. I'll ask Aid to answer around East Coast, because there is a specific programme of work. You're absolutely right. We need to we need to encourage those who are already living in that area to train through and remain in that area without coming out of the county. And then I'll ask Claire or Amy to pick up around the international recruitment and the work there. And then finally, Dr. Thomas to talk about the partnership, the GP partner issue in primary care, if possible.
Thanks, Kerry, absolutely, and thank you for the question. There is already a programme of work that we developed around 3 years ago using the Medical Education Centre at Pilgrim Hospital, Boston, working in partnership with the University of Lincoln to encourage widening participation, and also actually working with Boston College as a feeder into programmes there, initially for the Trainee Nursing Associate programme and also Foundation Paramedic Science programme, so that members of the community could access health and care training within their locality, so they didn't have to travel to the Lincoln campus, and that's growing numbers. And also there's ambition to grow those programs. Unfortunately, the pandemic retracted some of the activity, but there is ambition to grow into nursing programs, and discussions are currently taking place with the University of Lincoln around how that's delivered, but also in combination with the Campus of Future Living in Mablethorpe once that's up and running. In terms of medical training, Health Education England, through the Medical Education Reform Programme that I mentioned earlier, have taken a shift of moving trainees who traditionally choose urban centres for their training into rural centres, which is a fundamental shift to try and attract more trainees. As the evidence set out in the paper I developed whilst at Health Education England, if people train within a locality, they generally stay within 50 miles of that locality once they finish their training. So that's a huge ambition around the programme. But there's also the pilot programme of generalist doctors, which is really aimed at encompassing and embracing what we see within our population around, you know, some of the multiple illnesses. It's taken a very holistic view of medical training. So it's a multidisciplinary approach. It's very new, it's very innovative. It's currently being trialled in Derbyshire as the first pilot site, and then we will be locating trainees who choose to opt into the generalist programme, and it's already looking to be quite a popular option, to be honest, and locating them in the East Coast with the ambition that they develop such a niche skill set, a really innovative skill set in rural health and care, that they then choose to stay within the locality. I hope that answers your question.
Thank you. I noticed that Boston isn't, on your appendices, Boston actually isn't in the areas of deprivation, the high deciles, whereas Mablethorpe is, and that's quite a travel time. So is there anything planned for anywhere outside of Boston along the East Coast, is the obvious question.
Yes, absolutely. So Mablethorpe, obviously through the Campus of Future Living, trainees will be based there, hopefully in the accommodation once it's established. So it's actually that we'll encourage them to work along the East Coast. So it's not just going to be within one location, it's going to be multi-location. And of course, the Generalist Doctor Programme, their ambitions to work with PCNs, local communities, charities. So it's a very, very holistic approach to training in medicine. And we will use the breadth of the East Coast and what we see and feel in the East Coast to really enhance that approach to training. So absolutely, we're not just focusing on Boston or Mablethorpe or Skegness, etc.
Thank you. That's good to hear.
Thank you, Councillor Loughagan.
Thank you, Chair. I had a number of questions, most of which have been asked by other people, particularly around KPIs. I've got one remaining question. I'm aware of the comments on page 66 about promoting inclusion and belonging, but several times in my visits to healthcare settings, I have witnessed or seen overt racism towards NHS staff. And what I see everywhere I go are notices to say that violence will not be tolerated. Should there be notices to say that discrimination of any kind will not be tolerated? And should there be indications of what you do if you witness something like this, or if you are on the receiving end of something like this, with a much more active focus on it, because it is pretty horrible when you see it. Thank you.
Thank you. Really good question, and absolutely. So yes, that is. It's documented. It's part of the People Plan in Lincolnshire and nationally under the belonging pillar. So it talks about there are 3 strands that we're working with now. One is around overhauling recruitment to ensure that people can progress, people who historically might not have progressed, or there's a real or perceived barrier to progression. One is around the disciplinary gap, but the third one is around bullying and harassment. It's an overt policy now nationally mandated to NHS trusts to ensure that staff are protected from that nature of behaviour in the trusts. So there is a piece of work, and we are working with our fellow trusts to ensure that our staff are supported. We have lots of mechanisms within organisations where staff can flag if those things happen, and we are, much as there has always been a zero tolerance to that behaviour, there is certainly measures now in place to mitigate that and to eradicate it.
Okay, thank you for that. I've got Councillor Parkin, please.
Thank you. You'll be pleased to know these are more observations than questions. I'm really excited by it. Many years ago, about 5-6 years ago, I was actually a trustee of the Lincolnshire Refugee Doctor Project when it was in its infancy. So for me now to find it being discussed here at Health Scrutiny is wonderful. I'm still in touch with them on a regular basis, and so I don't need to declare an interest, but what is brilliant was that we started in Grimsby, working with North East Links, always with the ambition to move over to Lincolnshire. So it's really gratifying, and to really see embedded in the paper an understanding of what that scheme was trying to do from the outset. So it's wonderful. I've given my former colleagues a massive pat on the back. And I think sometimes the best solutions for these problems within our communities, and I think that's a really good example of where that's hopefully found, and I hope we'll carry on making a really prolonged impact into the health and social care system in Lincolnshire from now on. What I want to do, Craig, just really quickly as an observation to us, as a challenge to us, is link this back to some of the comments and some of the discussions from previous meetings. We have had the acute services review, we've had the papers on cancer care, and we are being told time and time again, everything to do in terms of the review was about recruitment, it was about retention, it was Lincolnshire becoming an excellent clinical model that would attract people to it, and yet there was a degree, quite rightly, of challenge from us to that. But I want us to be really clear that we need to link the two. That the two are absolutely intertwined. And I sometimes think we want to have our cake and eat it, and we want to kind of give robust kind of challenge to the changes, but this is why those changes have got to go. So we've got to link this to all of that clinical evidence that we've seen over the last year. And then finally, carrying on just from this comment about racism, which I think is a really valid one and a genuine one, I have had a couple of discussions recently from my wonderful residents in Louth, who they need a challenge as well. Because what I've had is actually residents come to me and complain that we're having too many people moving in from other areas, from down south and all the rest of it. And in fact, I think it's incumbent on us as public representatives to challenge those views. And so actually these people are potentially becoming, because of these massive challenges that we have in health, in dentistry, in education, in social care, social work, and that we actually need to embrace these people and for them to become integrated into our communities. Not sometimes our default position as a community is to resist change and resist people we don't know. We've got a part to play in that.
I'm taking your quote, best solutions are within communities. I think we've realised that we need community support to integrate new people into our county. It's broader than just recruiting people into posts. We're recruiting families into communities. And so this might not be appropriate, apologies, it's my first time here, but I'm more than happy to pick up offline with individuals here. I think there's some expertise in the room and clearly some experience that I would love to share with people. My email is on the report on page 58, so please, anybody feel free to contact me or any of my colleagues about anything that you've heard today, but I'd really value that conversation. Thank you.
Okay, thank you. You're happy to just quickly ask me?
Yeah, I think really what we need is to get you into LALC in the Association of Parish Councils, so that you really have an opportunity to go and liaise with those parish councils who are really embedded in those rural communities.
More than happy to.
Okay, thank you. Councillor Cleaver, I know you expressed to come back, but our next presentation, they've only got a set amount of time, so that's why I've not allowed it. Councillor Skinner, if you can be brief, if possible, please.
I'll be very brief. One of the sort of challenges to recruitment is also previous reputation, and we do have several organisations among the presentations this morning where people probably wouldn't want them on their CV. So we do really need to work at that, and that might hold things back a lot more than you think. Regarding overseas recruitment, we've lost them after a year. I would have thought if you actually encourage them over here, part of the package would be the length of retainment. That's just basic commercial common sense, rather than just hoping they're going to stay with you. Regarding Councillor Cleaver's very deprived Mablethorpe, I'll have to tell you, where the fluoride isn't all the way up the East Coast, there is very clearly deprivation. But going back to the original challenge, my heart's feel for you, because with the acute reconstruction, actual chopping it down, you actually have less training places. And once you have taken something away, it takes years to rebuild it. Thank you.
I'll pick up certainly the reputational one. You're absolutely right. for people, they are it's a sales process recruitment. You've got to sell the locality, you've got to sell the organisation, and we're working really hard. So some organisations within the system are more challenged than others. So as I say, we're working much more in collaboration. So for those organisations that are seeing their staff more engaged, maybe they are seeing a better retention of staff, seeing a high level, a higher morale, maybe. What are we doing? How are we supporting? Health and well-being is huge. There's the need to support our people and to retain them, because only then will we start to see the statistics. We have staff engagement measures in NHS Trust that you can find online, so we know where our trusts are placed regarding staff engagement. So that has to shift. So that's and CQC. You know, we have very, very obvious markers that people will look to when they look at a job to go to. So we can advertise and we can attract, but actually fundamentally we've got to shift that reputation as well. But people have very long memories.
Indeed, we have to be innovative and encourage people to come to us because we are innovative.
You're absolutely right. Absolutely right.
Okay, thank you. In which case, I've got one final question from myself, and that is on page 83, the fourth bullet point. It says that Health Education England report refers to a plan to interact with the local population to support successful rural workforce transformation. Is this something planned for Lincolnshire? And if so, can you elaborate on how and what would the timescales be?
Thank you. I will ask Adrian to do that, please.
Thank you, Kerry, and thank you, Chair. Yes, absolutely. So HE invested in a project manager to work alongside the Lincolnshire Workforce Transformation Manager to really move forward at pace with the ambitions. And actually, I work in United Lincolnshire Healthcare, United Lincolnshire Hospital, sorry, but actually I am the lead for this rural programme in Lincolnshire because I was the instigator of it. So HE have asked me to carry on and continue with this programme. So absolutely, we've asked the programme lead, who has just recently been appointed, to make a priority to really set out the strategy of delivery now. Based on the information that you'll have seen within the report, there are some guidelines around some activity that has to happen. But additionally, then there is also space to, via the People Board, to develop a programme of work and activity based around the specific needs of Lincolnshire. And we've discussed many of those today that we've listened to and heard, and actually we're aware of. So we will be progressing those, and they will be reported. We'll do an interim report. So we'll set out the strategy. We'll do an interim report, and then there will be a full measure or outcomes report at the end of the activity. The programme officer has been appointed for 2 years initially, so we've got quite a long programme of work to deliver, but actually the key priority is that this is delivered at pace.
Okay, thank you, that's helpful. In which case, I'm going to propose that we note the People Board strategy for 22-23, including the various initiatives to drive forward improvements in the overall staffing position, and that we seek a report in around about March 2023 to discuss the ongoing plans, where we will obviously have the KPIs, hopefully milestones and action plan brought back to us so that we can monitor it then. I have a seconder for my proposer. Thank you, Councillor Skinner. All those in favour, please show. That's supported unanimously, thank you. And just thank you very much for the presentation, all of you. So we much appreciate it. Thank you.
Thank you.
Right, we'll now move on to agenda item 7, the Humber Acute Services Programme. This item was circulated as part of the agenda pack on pages 123 to 144. We have got a PowerPoint presentation that wasn't included in the papers, and I would like to welcome our presenters via Teams, Ivan McConnell, Programme Director of the Humber Acute Programme, and Lindsay Cunningham, Associate Director for Communications and Engagement for the Humber Acute Programme. Apologies on keeping you so long. Hopefully we won't delay you too long, because I do know you need to be going on. So I'll hand over to you and we'll take questions at the end.
Thank you, Chair. Lindsay's hopefully going to manage to share her screen. We have sent colleagues a copy of a briefing now. We were asked to come to this session to just give you an update on progress, timelines, etc., and where we were So we will do that very briefly, conscious of your time also. So the next slide, Lindsay, please. Just to remind colleagues, there are a number of challenges probably that reflect just what some of colleagues from Lincoln have been saying across the Humber health and care system. We've got two core programmes which we are running at this point in time. One is around urgent emergency care, maternity, peds, neonatal and planned care, and the other is around a significant major capital expression of interest, which aligns to that for 720 million across the National Hospitals Programme. We've provided updates and briefings on that before, but we're now looking at the next slide, coming to a period that is quite critical for the programme with a number of dependencies. So we've been through a process where we've had a case for change that's been reviewed by Clinical Senate. That was reviewed in 2019. Around about November 2020, I took up the role to move this forward to get us to a pre-consultation business case, which clearly will need to be approved through overview and scrutiny, but given current legislation also needs to be approved by the Integrated Care Board and also NHS England. We've been through quite a comprehensive process of engagement as we've gone through that process and engaged with over 10,000 people. Lindsay's going to just give you an update on that, which has been recognised as an exemplar of national good practice. Going back to some colleagues' questions on data, we have travel mapped all patients by postcode to nearest hospital by activity, which hasn't been an easy thing. We have mapped all of our workforce, whether that be across secondary, mental health, community, voluntary and primary care, of where they are by grade, by skill, and understand what the implications of any potential changes would be on them, but equally map that to the local economy and the regeneration in town centre deals, particularly in the areas of Scunthorpe and Grimsby. Been through a range of assurance reviews, and we've just successfully completed a clinical Senate review that has agreed that our clinical options and models prior to evaluation are representative of good practice and deliverable. Key things really from this slide, just for colleagues to be aware of. Clearly, for us to go to consultation, we need that pre-consultation business case approved. That needs to be done by the Integrated Care Board. That board has just come together on the 1st of July. So that is what we need to do September, October, November. The latest I can go to consultation is the end of November if I am not to hit further. So consequently, we're working to an end of November deadline at this point in time, but that could slip. If that slips, we will not go to consultation because we can't legally until July of next year. We're also required to go through an NHS England gateway review. That review is planned and that gets sign off from the centre for us moving forward. However, if NLAG remains in soft 4, then that will have to be approved nationally, and there is a risk on the timescale on that. So I'm being very open with colleagues. That is a current planned timescale as to where we are, but that may change subject to those reviews and new bodies being in place. So Lindsay, over to you really just to cover the engagement piece.
Thank you, Ivan. And obviously there's a lot of information in the packs and links to the various different engagement reports. So I hope that members will have the opportunity to take time to look through them at your leisure. But I just wanted to give a really brief update today on some of the engagement work that we've done to support and where we've managed to get up to date. And I think we gave a flavour of this at the last session when we came to see this committee back in December. But over the last 18 months in particular, we've been engaging with members of the public, patients, service users, representatives of all of those groups, and also particularly our staff across a number of different methods, so including surveys, focus groups and workshops that have helped to support the pieces of work that we've been doing. I guess in particular, key things to highlight is we've worked with a lot of partners, for example, in the
maternity services arena, we've worked with our local Maternity Voices partnership groups and worked with the groups across the Humber, but also engaged with the MVP for Lincolnshire, recognising the broader geographical impact of our services. So all the way through, as we've designed each of these pieces of engagement, and you can see from the diagram on the screen some of the highlights in terms of the numbers of responses and the numbers of people we've engaged with. And we've tried to co-design them with the representative groups that are there, because obviously they have the really good links into communities, and we can draw on that those links and that understanding. So I'm struggling to change the slide. There we are. As I mentioned, there are links to the various feedback reports provided in the cover paper that we sent to committee. So I won't go through these in great detail, but just in terms of some of the findings and some of the pieces of information that have been used to inform the development of future models of care, some of the headlines in terms of what we've been hearing from patients, public and staff. And I'll just flick down to the next slide, which sort of summarises some of these key issues. Safety and being kept safe and looked after well was a critical factor from women and people using maternity services, as well as the staff involved in delivering maternity services. It is an issue that obviously has a lot of national headlines as well, a lot in the media, but it's something that's come through really clearly when we've engaged directly with the people who use those services. So a really key factor in terms of driving our evaluation framework. And one of the other things that's come up consistently, and particularly with our engagement with elected members across the whole of the Humber patch and into Lincolnshire as well, is issues around travel and accessibility. So as Ivan has mentioned, we've looked at travel impact by mapping all of our patients in that baseline year and understanding where they come from, where they travel to, and what would be the potential impact of any changes. And also workforce is a really key issue, not just from the staff that we speak to, but actually obviously you've just had a very long discussion around some of the workforce challenges, so I think they're well understood. But the public and the people that we engage with have also recognised that it's not just something coming through from staff. So in terms of where we are now, I think Ivan mentioned we've been going through quite an extensive evaluation process. This involved a number of different workshops involving different stakeholders, but also looking at each of the potential ways of resolving some of the challenges in our acute services. A number of workshops held before Christmas last year and then throughout March this year, supported by a comprehensive piece of evaluation, which is still ongoing but due to be completed soon. What we've done in terms of that analysis, we've mentioned the travel mapping already. We've also done some really extensive workforce modelling, so developing that baseline understanding of our workforce across secondary, primary, community care, mental health services. So we've engaged with the different partners to develop that really clear understanding of their existing workforce, where the gaps are, and also looking at how future models of care could be delivered with a different range of skill sets. So that's developing alongside the models so that we can do that really comprehensive evaluation. And the other key thing just to flag is we've also reviewed all of the models in light of the publication of the Ockenden review. So looking at some of the key issues around maternity services, some of the recommendations, and ensuring that the models that we will put forward following the evaluation are able to be delivered safely and meet all of the criteria within that report. The final pieces of analysis that are not yet completed is the economic impact assessment and financial analysis, and that will, when that's finished, that will complete the evaluation process, which will allow us to go through the assurance processes that Ivan has talked through. And finally, again, this was in your pack, so you can look at in more detail. The feedback report from the Clinical Senate review will hopefully be published in the coming weeks once the panel have reviewed and finalised their findings. But in terms of the headline feedback, they were very impressed with the work so far and gave a number of really important, helpful pieces of advice in terms of issues, particular approaches, and also looking at how we would take forward the evaluation process and confirming the potential models of care for the future. I think I'm just going to hand back to Ivan to talk about out of hospital.
I think calling this an acute review is a bit of a misnomer. One of the big things is that actually we have a lot of dependencies across the system. So we have worked very closely with colleagues on primary care, mental health care, community services to actually identify what needs to be in a hospital, what needs to be out of a hospital, but where are there areas of joint working? Because actually, if we look at the 40% of people who don't need to attend an emergency department, they can be treated in a better way through different skills, for example, in different settings, either at home or closer to home. So I think we need to challenge what we're doing. We currently have got a whole range of things, maybe picking up some of your comments earlier, that we're looking at. So we're working on a joined up connected health network with GP practices where we've moved cardiology out of hospital for outpatients. That's supported by digital, is supported by digital maturity assessments of patients, and they're provided with kit. And sitting within the practice, we've tested it in no patients waiting for a cardiology outpatient appointment within 3 months. So how do we scale that up? Going back to maybe some of your colleagues' challenges and questions in a previous session, how do we do that safely and how do we work that through? So we're building those in to the options we've got. We're working very closely with the operational delivery networks, regional colleagues. Academic partners as well are very, very important. I think we need to respect the fact that our universities are not necessarily that well advanced in their allied health professional training. Hull University, for example, have only started radiography training this year. You've got Lincoln Medical School, very, very welcome, but actually, its full cohort of students have just started to come through. So we need to be looking at that, but we also need to be looking at alternative skills, and we've mapped all that out as we've gone through. So the final slide really just gives you a summary back to the timeline of where we are, sets out where the key issues and the criteria are, and hopefully we've given you the confidence we've got some rigor and process that we've gone through. Those have been through quite comprehensive assurance to date. We have more assurance to come. But the key thing for me is we can only do that consultation when we get those assurance approvals. If they don't happen, it will be the middle of next year before we move forward. That gives us more time to do even more engagement, but there is a risk in that also that sits there. So thank you very much, Chair. Hopefully that's given you the briefing you expected and asked for.
Thank you very much for your presentation, in which case we'll move to questions. Are there any? No, I've got a couple myself. The first one is, the government has not yet made an announcement on the new hospitals programme and your bid for £720 million of capital funding. What is your plan B if some or all of this funding is not forthcoming? And do you know when will the outcome of the bid likely to be announced?
Yeah, I'll start with the second question. I get briefed probably weekly. So initially, we were told we'd hear in December, then January, February. Then we were told it was on Secretary. 21 organisations would be shortlisted to spend 12 months doing a strategic outline case. That was with the previous Secretary of State. There were Secretary of State visits planned to some of those sites. At this moment in time, with new Secretaries of States, changes in cabinet members, etc., then that's a little bit up in the air. So we don't have any definitive timescales. I think the key thing is National Hospitals Programme nationally has been delayed. The Pathfinder programmes are 2 years. If we're to look at rebuilding Scunthorpe Hospital, assuming we get on the programme, the earliest that build could be done is 2030 to 2035. So we need to make sure that we still lobby, maintain the infrastructure that sits behind our hospitals, because both Scunthorpe and Hull Royals Tower Block are at significant risk of failure despite the investment we've got. However, we don't need all of the money to allow us to deliver what we want to do. So the 60 million that I've got us to do our emergency department schemes with the 2 EDs opening probably give us the opportunity to optimise those models of care very, very easily. One of those opens next month.
Okay, thank you. And my second question is, will the pre-consultation business case due to be completed in July 22 be available to members of the public?
Yeah, it's 100% discoverable. So it will be there, that pre-consultation business case, until approved, however, by the Gateway team and also the ICB, is always classed as a work in progress document. But the point at which we go to consultation and plan that consultation and have got through those, that document will be available. At this moment in time, it's about 400 pages long. So if anybody wants a good read, it's there. And also, as Lindsay's alluded to, we've probably got about 6,000 pages of appendices that support that at this point in time.
Okay, thank you. I don't seem to have any further questions. So I'm just going to propose that we reconfirm the committee's position as set out in my letter of the 19th of January 2022, and to seek a further update at a later date when information on detailed proposals, including their impact in Lincolnshire, becomes available. Do I have a seconder for that proposal? Thank you, Councillor Skinner. All those in favour, please show. Thank you. That's supported unanimously. And once again, thank you for your patience and attending today.
Thank you, Chair. Thank you. In
which case, we'll now move on to agenda item 8, the work programme. Simon, I'll hand over to you.
Thank you. Thank you, Chairman. Before getting into this, if I could just respond to the question from Councillor Cleaver, which was made earlier on. Essentially, in the regulations, there has been a minor change to the regulations where the word clinical commissioning group occurred. Those words have been replaced by integrated care boards. So, in effect, the regulations are still current. So if you like, the powers of the committee still stand. However, at some point, we are expecting further regulations on reconfigurations, which will affect the Health Scrutiny Committee powers, but they may be at some point later in the year at this stage. Just moving on to the work programme, there are already 5 items on the list for September. And if there are any others, I think that we may need to think about, Chairman, the arrangements for the September meeting. In other words, perhaps even a break for lunch and sort of resumption at 2 o'clock or thereabouts. I don't think I've got anything else to add to the programme other than the next 2 meetings in September and October are quite full. So it is a busy time for the committee over the next 2 meetings. Thank you.
Thank you, Simon. Yeah, I think definitely be looking at scheduling a full day. Obviously, with having an August break, it does mean that the workload is slightly heavier. So, yeah, I think we'll schedule that for a full day and we'll look at October from there. Do I have any comments, please, on the work programme? Councillor Cleaver.
Yes, so thank you for that, Simon. I'm still not clear as to what our role will be in scrutinising whatever plans are made by the Integrated Care Board for the way in which integrated care will be rolled out. Now, I'm also conscious of the fact that it has been mentioned that PCNs will have a primary role in that system, but I've not seen anything actually put forward about that yet. But when that comes out, I'd like us to be able to scrutinise it, particularly in the light of the fact that we've not really, as far as I can remember, actually scrutinised the success of PCNs to date. So it would seem apposite to me. I don't know if anyone else agrees with me on that one.
Simon?
In terms of the new legislation, there are lots of things which are in the Health and Care Act which are dependent on subsequent regulations being issued. And at this stage, a relatively small amount has gone through. As I've just said, minimal changes, more or less deleting the word CCG and including the words ICB. So there will be a lot more coming on that. The primary care network, generally, the Lincolnshire Primary Care Network Alliance issues an annual report, and I guess that may be ready at some point, but it might be something to consider as a separate item. I know the focus of the October meeting is apart from the, there are 3 GP related items on the October meeting, but it may be something to take as a separate item, possibly, if I may say, rather not at October, but maybe at the November meeting, rather than trying to fill up the October meeting. But that may be something to look into as a separate standing item. Thank you.
Thank you, Simon. Yeah, I think it's fair to say we'll keep a close watching eye, but the legislation's moving slow and it will now move slower, of course. So we'll make sure we'll watch that, and obviously, yeah, we'll look at then scheduling that in November, because I think PCNs is probably something we're all getting quite a lot of hassle about, probably more down to the GP level side of things, of course. So we'll ensure that that does appear, and we'll take that over the summer season. So if that's everything. Yep, thank you. In which case, that brings the meeting to a close. Enjoy the summer break and safe journey home. Thank you all very much.